friends, colleagues, it's my honor on behalf of the organizing members of the organizing and scientific committee to welcome you all. As before, I would like to say good morning, good afternoon, and good evening all over the world. Today is the second day of the Emirates Critical Care Conference. It's our 16th in our age, and it's the first hybrid. That means we have people on site and we have people online from all over the world. It's local, regional, and international. For the second day, we have registration of around 3,200 plus, and it's from 60 countries, which attended also the last or the first day, that was on 14th. Our fight against COVID will continue. That's something we are sure of and something we know. It's going to extend. But we did build an experience how to deal with this virus. The one that changed our life from all perspectives. Perspective of technology, it showed us that technology is a very big help in our fight. It showed us that there are things which we used to do and could be done differently. Understandings and values in life, it merged, it changed. Now people came to understand more and accept more the importance of healthcare providers, healthcare workers, and how we can depend on them. It changed us how we exchange our experience, expertise, and knowledge, like what we are doing now. Today we will have 3 sessions. The first session will be about the concept or dealing or managing managerially the COVID-19. It will be chaired by Dr. Asad Al-Houfi and Dr. Ashraf Al-Houfi and Asad Al-Sabah, sorry, my friends. We will be having Dr. George Abi Saad from Lebanon, Professor Luis Blanc from Spain, Francesca Robolota from Italy, and Philip Lamb from United States. Second session will be about the medical management of COVID, where we'll be having Professor Asim Abdurazak from Egypt, Professor Reinhard Konrad from Germany, Dirar Abdullah from Dubai, and Dr. Farid Zan, Professor Farid Zan from Iran. Third session will be about the neurocritical care with COVID patients, organized by the Neurocritical Care Society, chaired by Professor Katja Wartenburg from Germany and Yasser Abul Hassan from Kuwait. Speakers will include Jose Suarez, who is the chairman of the Neurocritical Care Society, joined by Majid Mukhtari, Jamal Dipu, Mari Kay, and Sheni Chow, or Cho. There will be a session organized by our sponsor, Baxter, and I hope that you enjoy and get the benefit together. And I ask my colleagues to take over the first session. Thank you very much, and best wishes for you.
Bismillah ar-Rahman ar-Rahim. And welcome to our second hybrid conference, the Emirates Critical Care Conference. Our first hybrid, as you all know, was on November 14. This is the second one. We are starting our scientific sessions, the first session. Our first speaker is Professor George Abi Saad. He is the Professor of Clinical Surgery and Head of Trauma and Surgical Critical Care in the American University of Beirut Medical Center, Lebanon. He will be talking to us about COVID patients, how to operate. Professor George, the floor is yours.
Okay, good afternoon, ladies and gentlemen. I would like to thank the organizing committee for inviting me for this important Emirates Critical Care Conference. And my name is George Abissad. I'm the head of trauma and surgical critical care at the American University of Beirut Medical Center in Lebanon. And my talk will be how to operate the GI complications and surgery. I have no conflict of interest and nothing to disclose. The outline of my talk would be how to operate, what are the guidelines around the world, what are the GI complications. This is a very interesting part of the presentation. What are the outcomes of surgery, and what is the second surge, which is delayed or canceled surgeries during the COVID era. Let me start by a few reviews and published things from around the world. This is from a British journal, COVID-19 in the operating room, a review of evolving safety protocols. You know, people they didn't have protocols, they were really in a mess, and they lost some of the doctors, the house staff, and people got ill and they could not keep up with the load and the volume. So this one is aiming at the conclusion that the surgical staff needs to keep abreast of the latest literature concerning first safety measures, because if you lose doctors and house staff, who is going to treat the patients? And so in this article, they go on probably doing the normal operations and maintain a COVID surge plan, but if and operate if the condition is emergent, if there is an essential indication and the patient has high risk history, symptoms, fever, they would do it. However, if the surgery can wait, this is the most important part, that people should delay or delay or cancel the surgery until better times. And again, they go by American Society of Anesthesia. If somebody has a high ASA and is a risk factor to himself and to the house staff, we better delay or cancel the surgery. And it depends on the resource utilization. Can we have blood ready? Do we have ICU beds ready? So all these should be taken into account. This is not a one format to be applied to everybody, but this is definitely something that every hospital, every center should design for the system to be smooth. They divide the operating room into zones, which are 5 zones. The zone 1 is when the entry of the patient is done through the dressing room, where the basic personal protection equipment is donned. And then there is a room which they call the anteroom, where the disinfection is done and the surgical dressing takes place. And then we go to the operating room. So look as if they added in a room to make sure that the partition is safe enough. And then there is an exit room where we remove our PPE, and then an exit dressing room where the staff would showers. So this is really a guideline that people should follow in the operating room, the topic of my lecture, how to operate. And then the personal protection equipment is filtering face piece number 2. Number 3, if the patient is high risk and generating some droplets and particles, we should have disposable long sleeve waterproof coats, double pair of nitride gloves, protective goggles for the eyes, disposable head cups, shoe covers, and alcoholic and hand hygiene solution. You think that's easy, but unless we don't have a checklist, we are going to be lost, or we are going to be at risk as house staff. This is a busy slide. I don't want you to go through it, but this is from clinical anesthesia journal, Canadian Clinical Anesthesia, where every patient has a role. I just want you to look at the nurse in charge, how she activates the team, and then the OR runner who makes sure to fill the bottles, OR nurse who prepare the operating room accordingly, the anesthesiologist, anesthesia nurse. If this work in multidisciplinary fashion, and we refrain from entering the room unless absolutely necessary, then things will go smooth. This is the preparation phase, and then we move to the intraoperative phase, where we contact the OR runner if we require any other item. And then the post-operative phase, the transfer is very important because yes, we are done with surgery, but where would the patient go? To an isolation ward, to an ICU? This patient is infective. How do we handle the specimen? How do we remove the PPE and the popper? This is the powered air purified ventilator, respirator, and the disinfection guidelines, and then the follow-up phase. So, and then we should replenish all the supplies. Remember that every step will count. Like a pilot in a plane, if we have a good checklist, we will not go wrong. This is another paper from the Brazilian hospitals entitled How to Prepare the Operating Room for COVID-19 Patients, coming from different Brazilian hospitals. And the basic message from this article is how to maintain a good psychological atmosphere and attitude of the patients, and how to do the transfer and clear the patients for the patients who will come. Even centers who have never operated on COVID, the saying is you will eventually have to operate on COVID patients. There is no running away from this eventuality. Again, the American College of Surgeons, the American Society of Anesthesiologists, the Association of Perioperative Registered Nurses, and the American Hospital Association have have recently, on August 10, updated a joint statement, which is a roadmap for maintaining essential surgery during the COVID-19 pandemic. Of course, I don't have time to discuss it, but these are the items, and feel free to look at it. This is a very comprehensive list discussing the cooperation between the critical areas and to provide the essential surgery, the supply chain, how we test in the facility, the patient, the house staff, and everybody who is concerned, the PPE, how do we have a prioritization of the schedule, how do we delay or cancel cases that are not mandatory, how do we collect the data, how do we have the 5 phases of the surgical care we discussed above, the safety and risk mitigation, and the additional related issues. This is like a 9-page joint statement that is very important. Now, what have we learned in surgery as well? That minimally invasive surgery and the novel coronavirus outbreak, in the Annals of Surgery published article, we have lessons learned from China and Italy, and as Camus, the French writer, said, so all a man could win in the conflict between plague and life was knowledge and memories. So maybe this applies to COVID-19 as well, and we should learn. So in this Annals article, what are the messages? Is they share with us their recent experience that first, the general protection is very important. All surgery patients must complete preoperative health screening. Everybody should be tested with PCR. And then the prevention and management of aerosol dispersal by anesthesia people, by inhalation therapy, by the surgeons, by the nurse in the operating room is of paramount importance. What do we do in minimally invasive surgery? We should keep the intraoperative peritoneum the lowest possible, not to have high pressure on the lung, not to increase the plateau pressure, and not to contaminate with the CO2. with droplets. The operative technique, the power setting of electrocautery should be as low as possible. We should not create real fog from excessive cautery. The post-operative operating room and equipment management, all the protocols involving the cleaning and disinfection should be obeyed. Hospital should be immediately divided into two main categories. In my hospital, we have two buildings. One is designated for positive COVID-19 and the other for negative COVID-19. And the administration decides who circulate from one building to the other, maintaining utmost prevention protocols. Teaching and future recommendations to reduce occupation hazard should be always continued for aerosol exposure. The operating staff protection should be very important at all times, and we should raise awareness to every person working in the operating room. And then the preoperative health screening, in order to effectively win the battle against the prolonged 2019 COVID outbreak, it is imperative to establish new standards of practice for admitting patients in the future. In Boston, in MGH, they had, when COVID hit them, published in the Annals Design and Impact of COVID-19 Multidisciplinary Bundle Procedure Team. They had what we call a COBRA team that were stepped up to take the consults and do procedures and look at the peaks of procedures. They did the hemodialysis lines, central venous lines, arterial lines, and this is the number of procedures, 214 procedures. And the message was that this was welcomed by the hospital faculties and the departments, that this team really made it easy to cope up with because they had like 700 patients of COVID at one point in time in MGH Hospital in Boston. And now I move to the gastrointestinal complications in COVID patients. And the GI complication is very interesting. This is an article published in the Annals of Surgery when they showed that the presenting symptoms are diarrhea, nausea, vomiting, and abdominal pain. And the GI manifestations during admission, they have diarrhea in 30% and abdominal distension in almost 40%, along with constipation, nausea, vomiting, and this is a table of the complaints. So what is the prevalence of GI symptoms in COVID-19? In 60 studies on 4,000 patients, 88 come from China. The GI symptoms present in approximately 20 to 30% of the cases. And this is really a considerable number. We only talk about the lungs and the ARDS and the thrombosis, and we forget about the GI. This is really, I will show you why, very important. So is there an RNA evidence of a GI infection? Along the GI tract, in a publication in the Gut in April, they did an EGD showing the RNA distribution along the GI tract from the esophagus to the stomach to the duodenum down to the rectum, and the prevalence of RNA in the GI tract in 138 patients, 70% had a positive RNA in the stool, and it shows the prevalence. The RNA replication in the GI tract in Nature 2020 showed that there is a subgenomic RNA present in stool samples suggestive of RNA replication. So the GI tract harbors the RNA in its entirety. 50% of patients shed RNA in the stool. The stool RNA lingers up to 4 weeks, and we have RNA replication. Is the alimentary tract vulnerable to infection? Well, the ACE mRNA protein is very high in the small intestine and the duodenum, kidney, and gallbladder, and the colon would have it low the rectum, the liver, and the tongue. So indeed, the alimentary tract is vulnerable to the infection, and the entire alimentary tract is vulnerable to infection by ACE2 and TMPRSS2 expression. This needs further studies for the future. So in this article, the GI symptoms approximately are found in 1/3 of the patients. GI symptoms associated with the severity, the entire GI is vulnerable and has mRNA expression. The stool is 50% positive, and the virus invested into the bowel wall and intact architecture. So there is a strong argument that the COVID-19 infects the bowel, and there is insufficient evidence to conclude that direct viral infection contributes to GI pathogenesis, but the association is very high. So, and another publication in the GI manifestation in the critically ill, again from Boston, it showed the hepatobiliary complications, the high transaminases, the hypomotility complications, and look at the bowel ischemia. I will show you slides that are really very impressive, and other GI complications like bleeding and perforation. So paralytic ileus is known in any infection, but the bowel ischemia in COVID-19 that is so quick, the presentation is so quick that it has logically to be attributed to the COVID. Look at the bowel ischemia. These are pictures of real patients who have minimal comorbidities. The age is not that 30 to 60, they're not elderly, and the days of admission are 10 to 16, showing rapid clinical deterioration, and guess what? The mortality will be 40%. So this is bowel ischemia, and we think that it is related. Yesterday, we did a case here who was COVID positive, and 3 weeks later, she had a perforated cecum, and she underwent a double barrel colostomy. Quite dramatic. In another study in JAMA, the gastrointestinal complications in critically ill patients with or without COVID-19 showed that if we don't have it, look at the blue line, the patients without GI complications are the majority, above 50%, where if we have a COVID-19, like more than 80% have GI complications, speaking to the association again. COVID-19 coagulopathy, COVID-19, everybody knows that now has inflammatory coagulopathy, and the most important is the elevated D-dimers. So does prophylactic anticoagulation help? This is a study showing in JAMA how many 30% died within 28 days. And yes, the anticoagulation help, as this graph shows you, if the D-dimers are elevated. So it's not for every COVID patient, just for the elevated D-dimers, and the message here is clear. Now, how do patients with COVID-19 do after surgery? This is a study over 6,000 hospitals in more than 75 countries where 1,128 patients were taken, and the mortality and pulmonary complications in patients undergoing surgery with COVID-19 was that the outcomes we measured is mortality and pulmonary complications like pneumonia, ARDS, and unexpected ventilation. The study showed that there is a mortality of 23.8% more in the emergency surgery, and whether we do a preoperative or post-op diagnosis, it does not matter. It's not significant. The major surgery would be associated with a higher mortality, 27 versus 16, and how we do the anesthesia is immaterial. Actually, the local had a higher mortality, and the most important is the pulmonary complications are 40% with pneumonia, 14% with ARDS, and 21% had unexpected ventilation with a high mortality rate of 41%. Alarming numbers. And what matters is the male sex the age more than 70, the high ASA grade, the comorbidities 2 or more, whether the patient has cancer, the case is done on emergency basis, whether it is major. These are the independent predictor of mortality. And one of the final slides show that the mortality 30-day is 38%, and the pulmonary, post-op pulmonary complications is above 50%. And the conclusion is the post-op complications and mortality is higher than in the pre-COVID era. Surgery should be postponed and non-operative management should be used whenever possible. The last but not least, we have closed and canceled and delayed many surgery because of COVID and elective surgery cancellations due to the COVID-19 pandemic around the world. In a study from COVID Surgery Collaborative, 28 million surgery worldwide were canceled, 81% is benign surgery, 37.7% for cancer surgery, still they were delayed, and the elective surgery that were canceled in orange in Europe and America is very high. So millions of elective surgery were canceled worldwide, and these are some of the examples. And with 20% increased surgical capacity, it will take 45 weeks to clear the backlog. The second surge might be surgical patients who are delayed or canceled. And recently, the final slide is a study published 2 days ago in the British Medical Journal Simulation Technology Enhancement Learning, where the Apple Siri now, I don't have time to discuss it, is used between inside and outside the OR to minimize contamination. This is how it's being done with one earphone, and somebody is sitting outside. And you can read about it. This is from King Fahd Specialist Hospital in Dammam in Saudi Arabia, where freehand wireless communication by healthcare workers dressed in full PPE can facilitate communication and improve response time across the OR. So in summary, much about the COVID-19 remains unknown. Scientific studies are needed. The COVID-19 is a systemic disease with GI manifestations, notably mesenteric ischemia. Surgery should be avoided, and the second surge might be surgical, that of cancer surgery. And with this, I thank you.
Thank you, Dr. George. My name is Asad Al-Sabah. I am consultant intensivist from Mediclinic City Hospital. It's my pleasure to introduce the second speaker for this session, Professor Louis Blanc-Tora. He is Senior Critical Care Physician from Corporatio Sanitaria Park Tolly, Director of Research and Innovation. Park Tolly, he is Associate Professor of Medicine at the University Barcelona, Spain. He's going to talk about the importance of clusters of asynchronies during mechanical ventilation. Professor Louis, the floor is yours.
Good morning. It's my pleasure to be here, at this meeting in my colleagues of Dubai about critical care. The title of my meeting is the importance of clusters of asynchronies during mechanical ventilation. First of all, I would like to disclose my conflict of interest. I am inventor of 2 patents, which is software to monitor ventilator and monitor signals. I also founder of a spin-off of my institution, which is Better Care. So my topic is, the importance of clusters of asynchronies during mechanical ventilation. And I would like to start with this picture. This is a patient which is connected to the mechanical ventilator, and all the audience can see that this patient is suffering because he's not interacting well with the ventilator. This patient, is fighting with the ventilator and has cyanosis, tachypnea, diaphoresis. It uses all inspiratory muscles and all expiratory muscles to help breathing, and also has some hemodynamic disturbance. When that happens, this patient is prone to develop dyspnea, discomfort, delirium, anxiety, lung injury, muscle injury, and all this is considered that it might increase mortality. So we can consider asynchronous in this classification. Asynchronies that occur when the assistance from the ventilator is insufficient. Let's say the patient is presenting a high respiratory drive, and asynchronies that can occur when there is an over-resistance or, for whatever reason, there is a low respiratory drive. For the aim of that course, I will more focus on the high respiratory drive or with asynchronies when the assistance is insufficient. And the first what I would like to comment is when inspiratory flow of the ventilator is not sufficient and the patient has a sensation of flow starvation because, has a higher demand than that offered for the ventilator. This is the tracing of airflow. Flow is not sufficient because it's less than 40 liters per minute. And here, at each breath, patient has, a strong inspiratory effort, and look at that. In this strong inspiratory effort, due to the high drive, because the flow is insufficient, then, all the work of breathing in this breath, it's done by the patient, not by the ventilator. It could be another situation like this. Again, the flow, is low. The patient needs more flow because the ventilator is not satisfying, in that case, the patient's flow demand. And you look at the tracing in the airway, it looks like CPAP, and this is volume. This is assisted volume control ventilation, a square flow. So all the work of breathing, in that case, is done by the patient. And there is a strong swing in the esophageal pressure, which represent also, a large transpulmonary pressure. When that happens, again, this flow starvation can cause dyspnea or hunger. And the most important thing is that this is projected to the brain, the limbic system. So now there is data saying that maybe this can produce some kind of cognitive deficits in the patients in the ICU and also delirium. So asynchronies occur quite often during mechanical ventilation. This is a work by my group saying that in a number of almost 50 patients under mechanical ventilation that said that asynchronies, which is double cycling, breath stacking, effective effort, short and prolonged cycling, and all these compilate as an asynchrony index can occur right away from the intubation, until the extubation. And in certain patients, the percentage of asynchronies is really, really quite high. When we tried in a way to predict which patient can produce or can present asynchronies versus or asynchronies that can cause damage, compared with patients that do not and we would like to predict, this is totally unpredictable. We have here a patient that with a moderate number of asynchronies, and he is showing, a high asynchrony index at the day 6, 7. Never during the course of mechanical ventilation, this patient at the beginning and all time under mechanical ventilation. So we need to pay attention. And also here, it seems that in that paper, although it was not designed to study outcome, asynchronies, it looked like associated in that case with mortality. So we need to look at whether it's asynchronies or how asynchronies happen. After that paper, we were really worried and we tested the hypothesis that are asynchronies, just an asynchrony index higher than 10% associated in that case with mortality. And we did this complex paper, 140 patients. We study all the time under mechanical ventilation, and we use this type of analysis using Bayesian joint models for the analysis of something that happens continuously, like is asynchronies, and we found that compared with SOFA, that all of us use as to, in that case for assess, severity, SOFA discriminates perfectly the patients that will live, that the patients that will die, almost perfectly. However, asynchronies, even it seems that asynchronies are certainly a little bit associated with life. And in a way, this makes sense because when the patients, we take out the sedation, they start interacting with the ventilator, they start moving, and so on, it to a certain percentage may present asynchronies. So maybe we need to think on permissive asynchronies, Having said that, the characterization of the asynchronies is very important. And this is exactly what Vaporidis and Georgopoulos, did. They characterized not only asynchronies, but clusters of asynchronies, which is associations of asynchronies, and they define a cluster as a 3-minute period with more than 30, asynchronies, in that case, ineffective efforts. In that cohort of patients, in 1 day, patients difficult to wean in the ventilator, they found that clusters of asynchronies were associated with ICU and hospital mortality, and the mean power and duration of the cluster was important. I'll show you here another cluster. These are not ineffective efforts, these are double cycling with breath stacking. What's double cycling? Double cycling is when the inspiratory time of the patient is longer than the ventilator inspiratory time. Therefore, there is a second breath without expiration in the middle. It's 2 breaths without expiration. That means that tidal volume is double, and also the pressure in that case is double. This can happen from time to time, or as here, it can happen quite often, and then using the definition in that one of the definition of the clusters, if that happened more than 10% that we use in that paper, we see that this is a cluster of asynchronies, as you will see here, which at certain power, which is 61, which is the number of asynchronies in this duration, 26 minutes. So maybe, this is important. Having said that, we posed the question that, okay, if the Georgopoulos group found ineffective efforts is important, and we found that clusters of double cycling and breath stacking occur frequently, let's answer the following question. Are clusters of asynchronies important during the course of mechanical ventilation? In any type of critical ill patient mechanical ventilated, we study the combination of double cycling and ineffective efforts. Again, this is a patient. The patient breathes with asynchronies, and here is a cluster. If we amplify, in that case, this period, I don't know if 1 or 2 minutes here, you see the cluster again, double cycling with breath stacking, again, and this configurates a cluster. Having said that, we measure clusters per day, and all the patients had clusters. And then we measure clusters during the total time of mechanical ventilation, the first 24 hours. This is submitted now for publication, and in the rest of the time under mechanical ventilation. And during the first 48 hours, there are less clusters, but the power and the duration is the same in all the 3 periods. Total time, first 48 hours, and from 28 hours from the final of the mechanical ventilation. What we found in that paper? All patients, patients in the ICU, clusters of double cycling and ineffective effort. All them have clusters. To have clusters is positively associated with survival, meaning that interacting with the ventilator do not mean bad outcome. But power and duration is negatively associated with survival throughout mechanical ventilation, or even during the first period where clusters are less. If these clusters are at the determinate duration and a determinate power, okay, these clusters can, in that case, be associated with the poor outcome. So the answer here is that the patients interact with the ventilator, but how this happens is what determines, in that case, prognosis. Let's introduce another asynchrony. The other asynchrony is the reverse triggering, all you are familiar with. But this is a paper that's now in press, this is ready to appear in the literature, that with the group of Brochard, we analyzed some patients of the Bayer study in order to have an automatic algorithm to diagnose reverse triggering. And look at, reverse triggering is a breath which is originated after, okay, a passive breath from the ventilator. This is a passive breath. The patient is not doing any effort, as you will see here. This is the tracing of airway. And in the middle of the inspiration, this passive ventilator breath, is the origin of a patient's inspiratory effort. Okay, this is a mechanism that now we know that this occurs often, and when this reverse triggering is associated with breath stacking, let's say 2 inspirations without expiration, this is associated with the a swing. A huge, in that case, swing of negative pressure. As you will see here, there is a deflection in the esophageal pressure of 14 centimeters of water, which is much, much higher when a reverse trigger breath occurs without breath stacking. So in this paper, we show that, when that is occurring, let's say a breath of reverse triggering with breath stacking or without breath stacking, the effect on the muscular pressure is quite different. Reverse triggering without breath stacking, which is that one here, more or less the muscular pressure, occurs between 0 and 10, as you will see here. However, when there is a reverse triggering with breath stacking, this muscular pressure is quite high, and this can be the origin of patient-inflicted lung injury because the swing, there is large transpulmonary pressure, more deformation, and also pendulum, which is a movement of the air inside the lung that goes from non-dependent to the dependent zones. This is when reverse triggering cannot occur because these are synchronous pressure support ventilation, and this is the muscular pressure associated in that case with that. Again, is that reverse triggering, with breath stacking important? So what I show you is some results in the software that we are using to automatically detect asynchronies. You can see here that, again, it seems that there is asynchronies. Reverse triggering, double cycling, breath stacking occurs quite often. And when we look at specifically in these 12 hours, it see that almost 2,000 breath stacking and more than 6,000 reverse triggering is occurring. Probably, and this happened in one night. Perhaps this is enough to causing injury to the patient. So we need to investigate more on that. So you ask me questions and answer, which is the difference between a good about asynchrony. If asynchrony is associated with mild inspiratory effort without causing discomfort or dyspnea, it could be considered at least non-injurious. About asynchrony is the one that causes excessive strain, stress, fight the ventilator, and projection via afference to the limbic system. This is clearly about asynchrony. Some information on COVID RADS. So you are familiar of the pathophysiology of the pandemic. The virus is cytopathic, for the alveoli, and also causes thrombosis, and this origin in the first times, hypoxemia, and then as that space and chant in that case worsens, there is increase in respiratory drive, in respiratory rate, in respiratory effort, and dyspnea. Here is again, a patient breathing in the ventilator. This is flow, pressure, and tidal volume. And here flow is 60 liters per minute, which it seems enough to satisfy, flow's demand in a regular patient in the ICU. However, this patient is showing, a huge flow dysynchrony. Let's say the patient triggers the ventilator, but of course it pressurizes, but since the inspiratory effort continues, there is, again, an increase in the swing in esophageal pressure, originating in that case, a large transpulmonary pressure. This patient is fighting with the ventilator in a condition that maybe the flow is sufficient. That's why we need to investigate other causes of high drive in this patient with COVID-19 RADS. Snow and co-workers also characterize this phenomena because in COVID-19 RADS patients, they measure PO1, and also they measure, the swing in the pressure when there was an occlusion. And they found that the patients showing a PO1 higher than 3.5 centimeters water or a large, pressure after an occlusion, the relapse, let's say the probability, to be returned to the mechanical ventilation in that case was high. So this high drive may have deleterious consequences. And when that happens, we should not forget that a strong, spontaneous effort, it does an heterogeneous, regional, produces an heterogeneous regional ventilation and pleural pressure. You will here look at that the pleural pressure in these dependent juxta diaphragmatic zones that is higher compared to the other parts, of the lung. This can cause deformation, pendulum, air from here to here, and also excessive stress. If this happens in the alveoli, it also can cause, in that case, hemodynamic consequences, because in the capillaries, there is a strong effect of these large swings of, intrathoracic pressure. Here is in a passive mechanical breath, airway pressure is 30, pleural pressure is 10, and you see that the transpulmonary pressure is 20 and the transvascular pressure is 2. However, when the swing in the pleural pressure is high, there is a strong inspiratory effort, the transpulmonary pressure, if we assume that this is -20, is 50. And the transvascular pressure is 28, and this may cause increase in interstitial fluid, increase in edema, and also damage in the alveolar capillary membrane. Having said that, are asynchronies important in COVID patients? And I look at PubMed. I put COVID, coronavirus, and SARS, and I found more, this is October 24. I found more than 80,000 results. When I add patient ventilator interaction, this goes down to 53, and when I add only asynchronies, this goes to 8. And these are the two papers that I found. It's just case report, series of 9 patients. This auto report a very high respiratory drive, that could not satisfy the air hunger sensation of the patient. This generates an excessive inspiratory effort that these authors nicely describe, that this culminates in several multi-triggerings, which is double, triple cycling with breath stacking. This is associated, as you know, with injury. These other authors also quantify using a deep learning algorithm asynchrony throughout mechanical ventilation in 7 patients, and they found that they present definitely lots of asynchronies, and this is tracing the patients that survive, the patient that not survive. There is no difference. This is just observational to show that asynchronies may happen quite often. Again, 1 patient in our unit. Here again is decelerated flow, and the flow, again, here is near 60 liters per minute. But however, look at that. This is reverse triggering. So this is a time cycle breath, which in the middle or very at the beginning of the inspiration, the patient again inspires, okay, and has, a large transpulmonary pressure, as you will see here, and this is repeated in this 4. Here, the patient triggers the ventilator, okay, and here again is reverse triggering. So this tells us that these asynchronies can happen quite often. These asynchronies can happen with patient trigger breath in the middle, and we need probably to pay more attention to that. This is another example, but here in a square flow volume control ventilation, just to see that this happen in the 2 modes. Here flow is 45, maybe there is some effect of flow, but again, this is reverse triggering, reverse triggering, reverse triggering. Let's say this is a completely time cycle ventilator breath, which later on the inspiration, the patient has an inspiratory effort, the swing in that case in the airway pressure is 14, which means that there is a large transpulmonary pressure that can cause, strong effort, large pulmonary pressure, Pendeloop, deformation, and patient-induced, in that case, perhaps, patient self-inflicting lung injury. So let's talk about clusters, which is the talk. These are 2 patients. So when we look at that clusters in these COVID-19 patients, we see clusters that we never have seen that before. This is the power of this 10 hours cluster, 1, 2, 3 clusters. Almost all the time with more than 3,000, which means 3,000 asynchronies inside the cluster with this duration. And this is a cluster that lasts, as you will see here, 12 hours with the power of 14,000 duration, 12 hours. We need to pay attention to that because maybe this is associated with poor outcome, but we need to investigate more. So just to begin to conclude, when we look at in the lung safe the use of myorelaxants, which is one of the indications of myorelaxants in patients with RADS is to facilitate patient ventilator interaction, is one of the main indications. It says that in severe RADS, 38% patients were treated with myorelaxants. When we look at the COVID-19 series, we see that in this series more than 700 myorelaxant, 79%. In almost 5,000 patients, the French group 88%. In my institution, more than 80%. The group on New York, only 27%, but again, this series, 84%. It seems that in COVID-19, there is a high drive. And when the patients are in high drive, we as clinicians use neuromuscular blocking agents to protect the patient of this high drive. If this, I'm sure that at the bedside, we can interpret or see clusters and we react, treating with myorelaxant to protect the patient. Of course, it's more, this needs more investigation. This is completely generating hypothesis. So the last question, in your opinion, why COVID-19 patients develop more asynchronies? Because some of them present with high inspiratory efforts during the course of mechanical ventilation, which are associated with large transpulmonary pressure and lung tissue deformations and capable to inflict lung and diaphragmatic injury. So having said that, I would like to conclude with the image of the 5th intensive care unit that we created in 7 days in another building, in my institution, because I would like to thank all the professionals that fight in the pandemics, nurses, technicians, physicians, and so on and so on. So thank you to them.
Thank you, Dr. Louis. Please, you can stay with us till the end of this session to answer the question and discussion. It's my pleasure to introduce the third speaker for this session, Professor Francesca Nobolotta. She is consultant in anesthesia and intensive care medicine. She is the chair of IWIN, Imperial College Healthcare, NHS Trust from United Kingdom. She's going to talk about mortality in COVID ventilated patients. To Francesca, the floor is yours.
Hello, everyone. Welcome to my office in London. I wish to thank Professor Hussain and all the friends in Dubai for the invite. I miss not being there, but I hope you all keep safe and that we will be together in the future. The presentation I'm giving today is about the mortality in patients that had COVID and were admitted to the intensive care for the purpose of invasive mechanical ventilation. We are now in London starting experiencing the second wave. Most of the results that are presented today relate to patients we admitted in the first part of this pandemic. We realized that potentially the second wave will have a different behavior. We will manage patients in a different way. So we are not 100% sure how much of these data will apply to the current time. Nevertheless, we felt that it was really important to look at the results of previous studies to give a guidance for the future. I have no conflict of interest, but there are a lot of evaluations, data that I will not be able to present in these 20 minutes. So please take a screenshot or just note my Twitter account and email address so that we will have the opportunity and possibility to ask me directly. And I hope I can give you further information. When the pandemic started back in March, February, March, I will say, we were very much concerned about the availability of a mechanical ventilator. And a lot of our managers and politicians felt that having a ventilator would save lives. This was not exactly the case. As a matter of fact, human factor, resources, time were more important than the ventilator per se to allow those patients, to give this patient a better outcome. But this is a lesson we learned over time. You can see in this graphic from March to May, we had a very fast increase in the number of admissions, and our leadership was giving direction in the sense that one patient could be looked after by less nurses and one intensive care doctor was meant, in the case of surge, to look after up to 60 patients. Every single of these patients were extremely challenging, and as a contrast to the direction we were given, every single of these patients was taking more than the time that any other RDS, pneumonia, or sick ventilated patients normally takes during our ward round. So you see, there was a big mismatch between the knowledge, the resources, and the time availability that we had to offer to these patients. Therefore, we think that a lot of the mortality data have been affected by a series of variables. First of all is the time to onset. We had a very good network, the community worldwide in intensive care joined together. So we really managed to have fast information from our colleagues so that the more cases we had, the more information we could share. And we felt that the longest we were talking about the management of these patients, the better we could treat them. Therefore, the geography was also important, not just in the sense of the continent, the place, but even in the sense that if you were not in the epicenter, busy cases, you were able to have more care, more time, and therefore the outcome was better. Oh, this was the assumption at the beginning of our study. Resources were really crucial, and these were not just technology, but related also to staff, and in particular senior staff. We had people helping from whole specialty, nurses and doctors coming to support us, but unfortunately they were just learning about intensive care and they became confident over time. Therefore, there was a learning curve before getting them to be efficient. We also needed to readjust our shift so that we needed to have people that could intubate, could prone, could manage only few of the several different aspects of care for COVID patients. The knowledge, I think I'm still grateful to my friends in Italy because I was among the first doctors here using steroids. Now we have very clear protocols and support, but at the beginning, the knowledge was highly limited. Patients' age, we know that some patients could not be admitted to the intensive care, and among the evaluations and the elements they took into account, age was sadly one of those. The gender, once upon a time, women did suffer for less severe pneumonia compared to guys, to men. Patients' comorbidities were relevant. Staff was really concerned. We did not know what we were treating, and according to the guidance at the beginning, we were concerned about aerosol generating procedures. So we tend to oversedate our patients. We tend to intubate all of our cases, not just for the patients, but also to protect the staff. This might have an impact on the overall mortality. And definitely the logistics and the timing on we received the patients, whether that was at the end of a day that was bringing to intensive care 10, 20 new cases, or was at the beginning of the pandemic, these elements might have impacted the overall results. So what we wanted to do, we wanted to look at all the publications that were related to the outcome of adult patients admitted to the intensive care for the purpose of invasive mechanical ventilation. So we noticed that the case fatality rate of patients admitted in the first wave was variable, and the way it was reported was extremely heterogeneous. And our concern was that such heterogeneity could affect decision-making in the setting of limited resources, limited time, and work overload. Lots of new paper now are bringing out the level of burnout that people experienced at that time. And definitely we know from other studies that burnout has a direct implication on patients' outcome. We therefore selected a large team, fairly large team, 2 authors independently review the most common search database. We also refer to a living review. This was a living systematic review that started before this pandemic and was used before, for instance, for looking at data on H1N1 and other emergency. We looked to the National Registry database, and in particular, we concentrated between the start of January 2020 and August 2020. When conflicts were present in between the 2 independent authors, discussion was taken, and if the discussion was not bringing to a final agreement, a 3rd investigator was called, and he would make the final decision. The search terms were as follow. You can see mortality, fatality, intensive care unit, characteristics, invasive mechanical ventilation, death, and died. We decided upfront that we will contact all the authors of the paper that we will select, because we realized that at the time of publication, some patients were still ventilated into the intensive care, and therefore we effectively were not sure about whether they survived or they eventually died, and this could alter the final report. The eligibility criteria were therefore studied of adult patients that had confirmed COVID-19. We did not include, therefore, the pediatric population. We did not include small studies, less than 10 patients. We did not include not original research. And also, in the case of 100% death, we did not take into account this type of results. Because of the heterogeneity and also the speed of these publications, we decided that we had to make some definition on what we refer to. So we, for the purpose of this manuscript, we refer to reported case fatality rate for all those cases that were reported in the original publication. These obviously do not take into account the patients that were still in the intensive care at the time of publication. Therefore, we agreed that we could look at what the mortality would be if all the remaining cases would have survived. And this was reviewed using a sensitivity analysis and defined as the best possible result. And then we looked at the same cohort and pretend that all the ventilated patients still in the unit were dying. And this, through the sensitivity analysis, was considered the worst possible CFR. What the definitive hospital CFR was is the result of the consultation with the authors of the paper and the re-evaluations of the reported CFR based on the real results we receive. It's very sad that this was only 26% of the cases, but still gives us important data that I will be very happy to discuss if you want to contact me. So the primary outcome was reported CFR as we find it on the paper. You will find in the manuscript the definitive hospital CFR. You will not find the long-term follow-up for those cases for obvious reasons. We also analyze the CFR based on age, on the geographic region, and on the quality of the study. And we use the NOS scale for assessing quality of the study. And the reason why we looked at age and region is related to what I explained in the introduction. The method of the meta-analysis was reported using the PRISMA framework, and you can find the more information on Prospero. We carefully selected patients that were receiving invasive mechanical ventilation and not all the patients in the intensive care unit, because we do not know practice. And even if we can assume that everyone at the time of the first pandemic in the intensive care was ventilated, we cannot be 100%. So we wanted to reduce heterogeneity and specify that we all looked at patients with invasive mechanical ventilation. So this is our flow chart. You can see that we collected cases from the database and additional abstracts and data were extracted manually. We removed duplications, we screened them, and as you can see, we eliminated all pediatric cases, small size cases, and those reporting 100% mortality. And at the end, the agreement was that 69 papers could give us information related to CFR. We divided in this graphic by continent. You can see there is a variability where Europe still show quite an overall low reported CFR, and the overall result states that mortality in the first wave for adult patients was around 45%. For our friends in the Middle East, results was a bit higher, showing a 52% of reported mortality, CFR mortality rate. What if we look at studies and we divide them based on the quality of the studies according to the NOS scale? You can see that there is high heterogeneity, which is a limiting factor, but the good studies, those that have good quality, have a CFR overall of 46%, which is not far from what we reported in the previous slide. Those with a fair quality, the CFR is 48%, and it goes down in the studies with poor quality. Overall, the mean is again 45%. What about the definitive hospital mortality? This is once we collected data, real data from the cases that were still in intensive care at the time of publication, the results suddenly increased to 56%. And then what happens if we look to, as I explained, the case scenario where all the remaining patients die or all the remaining patients survive? So the best possible and the worst possible outcome. There's a significant range, significant variability among countries. And this is concerning because that shows a high heterogeneity and how much the information can be variable. You see, in Europe, that has overall good results, we can range from 38% to 57% with a huge variability. The Middle East, I need my glasses, getting old. We can range between 55% and 78%. That is a big difference when you are to make a medical decision at the bedside. Overall, the range, so the best possible scenario shows 43% and the worst possible 67%. What about age? So we looked at increase on reported CFR based on age. And you can see that is the orange bar are those that died. There's a correlation, quite significant correlation between CFR and age. It's quite dramatic. If you see patients over 50 have a much higher mortality rate, 61 to 70 is their highest. We cannot give total explanation, final explanation. We can only make assumption. Certainly the outcome is worsened by age, but we don't know really whether these patients, you can see the number is not so high, but we don't know whether these patients over 70, over 80 were admitted to the ICU, and we don't know whether the elderly actually were withdrawn at the time where we had no more ventilators, no more resources. So we cannot really make much assumption around these data, but it's quite concerning, and the relationship is fairly linear. You saw beforehand the range divided by continent among the best possible outcome and the worst possible outcome. But what if we look to the epicenters of this pandemic? So what if we look to the reported CFR for Wuhan versus the reported CFR for China? Well, you can see, first of all, the heterogeneity of those studies is much lower when you look to the same regions. And if you extrapolate mortality in Wuhan versus the rest of China, actually there is a significant difference. Maybe it was related to a lot of human factor. We got definitive data, we got similar data in the United States, where we look at New York versus the rest of the United States, and there is a trend. It's not as significant as Wuhan, but there is a trend showing that actually epicenter suffered more than the rest of the continent. What about definitive? And this is a more precise evaluation. In Wuhan, the number rise up to 95%. The rest of China is increased also to 73%, but the heterogeneity, once again, is much lower within the epicenter. Shocking in the United States, when we got final data, not from all the study, but the results jumped up in the 50 to higher than 80%. And here you can see a huge difference between the epicenter and the rest of the country. This is a study that has several limitations. We discussed already about the heterogeneity, and this is not different from other meta-analyses that have been published in other journals. Clearly, looking at the same area, the heterogeneity is less. And this is something that we need to consider, because we are now hitting the second wave, and to understand better or more about the management and the outcome of these patients, it's really crucial to present data in a comparable manner, in a comparable form. Is that 45% a number that is far from reality? As I said, we don't know, because we are now hitting the second part of this pandemic. But looking back, 45% was mortality reported on ventilated patients at the time of SARS in 2003. And even higher case fatality rate was reported in the Middle East respiratory syndrome. What about flu then? Flu has a better outcome. The CFR is lower and ranges around 24 to 26%. But if you look at IRDS, bacterial pneumonia, severe pneumonia, we go back to a CFR of 45%. So what's the take-home message? I suspect this so far is the largest systematic review and meta-analysis present. The reported CFR for this study is 45%. If we look to the definitive mortality, number go higher. And if we look to the range between the lowest and the best possible outcome, we have in the order between 43 to 65%. These are indication. Obviously, you should not make decisions based on this study, but I think it's important to understand lots of the details and all the variables that are presented when we talk about CFR at the end of the first peak in the pandemic. I wish to thank all the people that have been working for this systematic review and meta-analysis, Zee and Ash that have started the project, and all the Australian colleagues. I wish to thank the team from Rome, Federico Billotta, and the United States with Randy Curtis. That was really an international effort, and I hope the results will be useful for my team as well as your team at the bedside. I conclude by inviting you to next year's meeting, which I hope will not be hybrid, might be face-to-face. It's very hard to predict, but if we will be able to control this pandemic, I hope to see you next year in Italy, end of June, for talk about equality and diversity. Please send me questions. These are my Twitter and internet links, and I thank all of you, and please stay safe.
Thank you very much, Francesca, for this valuable information, and please stay with us because probably there will be some questions related to this data which have shown a lot of discrepancies between the epicenters and the other areas early and late during the pandemic. It gives me now great pleasure to introduce our last speaker for the first session, Professor Philippe Lamb. He is the Professor of Anesthesia and in Trauma Surgery, as well as the Director of Research and Data Analysis in the Department of Anesthesia in Keck School of Medicine, University, South California, United States. He will be talking to us about ethical considerations in medical practice. Professor Philippe, the floor is yours.
Good afternoon. It's a great pleasure to join you this afternoon in this innovative conference organized by the Emirates Critical Care Conference Group. While we cannot be together in Dubai, nonetheless, we are privileged to be able to share ideas concerning the COVID-19 pandemic, experiences and lessons learned. This afternoon, I'd like to thank the organizers for including my presentation, Ethical Considerations in Medical Practice, with specific focus on evidence-based medicine, clinical research, and quality improvement. As we have learned over the past several months, the speed of innovation and the speed of change in our specialty is rapid. There have been thousands of research protocols and tens of thousands of research publications, all of which have been focused on COVID-19 or SARS-CoV-2. As we have learned, very little of the therapeutic armamentarium has proved beneficial, and one of the most powerful objects and treatments we have is evidence-based critical care practice engaged in by individuals who work in competent and highly protocolized intensive care units. In order to look at ethical principles for research and clinical care, we need to understand where they come from and what they teach us. Recognize that we're talking about research, which is based with human subjects, but at the same time, we're discussing daily clinical care, which is our patients, the individuals for whom we have the highest respect and owe our highest skills. So where do they come from and what do they teach us? We're going to learn that over the next several minutes. You've all heard that they are beneficence, non-maleficence, respect for persons, and perhaps one that's not quite so commonplace, justice. So why do we care about them? Where did they come from? And what do they mean in daily patient care? And as we move forward in terms of quality improvement activities, we also start coming into clinical research protocols. Why do we care about principles? Well, they're the foundation of all research but they're also the foundation of evidence-based care of human beings. And to a certain extent, these two terminologies are becoming slightly intermingled. They're important because they inspire and they support society's confidence in not only research concepts, but they support the biomedical research autonomy and the ability of that autonomy to enable change and nimbleness as we adapt clinical care to changing realities. Never has that been truer than in the current practice of medicine during COVID. Therefore, they provide us useful tools to aid in the design and the approval of clinical and research protocols. And finally, they're a set of rules and procedures that enforce our humanity and our humility, while at the same time driving improvement in the care we give. Now, we can go back to any number of dates, but I think probably the historic ethical principles come from 1900 Prussian prohibitions, where it was very clear that the subject competency, the ability of an individual to understand research, the requirement to provide that individual informed consent, and that there must be full disclosure of experimental risk. However, and unfortunately, those principles were abrogated during World War II, and in the late 1940s, the Nuremberg Code following that war reestablished and reinforced the concepts of voluntary consent, but now it said that the results of experimentation for clinical research should be for the good of society and not to be an experiment upon individuals for experimental purposes alone, and that the subject should be at liberty to discontinue at any time without fear of retribution. Where did we sort of come in slightly more modern times? Well, in 1966, Henry Beecher, an anesthesiologist, published a study in the New England Journal of Medicine that lamented the fact that even though the Nuremberg Code in the 1940s had defined certain principles, which we'll come to in a second, nonetheless, that in his study of articles published recently in the New England Journal of Medicine in 1966, those informed consent aspects had been woefully inadequate, and that subjects had had very little consideration by the researchers, nor had they a great deal of knowledge about the trials they were entering. In 1932 to 1972, a study supported by the United States Public Health Service in Tuskegee County, Alabama, exposed Negro men from 1932 to 1972 suffering from syphilis to look at the natural progression of the disease, despite the fact that penicillin was subsequently introduced to the marketplace and could have saved many of the individuals from suffering and death. When in 1972, investigative journalists published their investigation into what was going on, the subject was immediately terminated. That led in 1979 to the Belmont Report, which was really one that began to define research accountability, that defined that accountability as respect for persons, beneficence, and justice. So where do we find ourselves? Well, there is a tension between clinical care and clinical investigation, and ethics in the old definition of the word was more about protecting the patient rather than the new definition, which provides access as long as two primary tenets are undertaken. The most important of which may be autonomy, and that recognizes that the individual is responsible for his or her actions and can indeed, when properly informed, consent to enabling researchers to enroll that individual in a clinical trial. Justice is a slightly more amorphous discussion, but it really means that if a drug is to be used across a variety of patients, then each of those patient classes needs to be included in the clinical trial. One might question the current vaccine trials that are primarily being engaged in by young, healthy volunteers, and yet the vaccines ultimately will be given to the elderly, infirm, and people with coexisting diseases. And we may be finding later dangers that haven't been elucidated in the earlier trials. Going back to Germany, in 1931, two very definite distinctions were made. The Germans recognized that there was therapeutic experimentation and modes of treatment which serve the process of healing, even though the effects and consequences cannot adequately be determined. I think we would all argue that that's the basis of clinical trials today. versus human experimentation, which consists of operation and modes of treatment carried out for research purposes which are not therapeutic and are absolutely inappropriate, unethical, and no longer considered. Leading to the Nuremberg Code in December 1946, which really leads us with two primary principles, the first of which is that the voluntary consent of the human subject is absolutely essential. That means two things. The subject should have the legal capacity to give consent, but also the subject should be in an environment that is free of, that enables free power of choice, free from force, fraud, deceit, etc. So experimentation with individuals who are incarcerated in jails, members of the armed forces, patients in other organizational situations in which they may be feeling compelled to participate, such as college students or people in training programs. So it is important that we recognize voluntary consent, and that during the course of the experiment, principle number 9, the subject should be at liberty to bring the experiment to an end at any stage without fear of retribution or redress. In other words, the patient should be confident that even should they withdraw from the trial, that their treatment will not be compromised and that they will continue to receive the finest possible care. This is really all about respect for persons, which incorporates two basic convictions. The first is that individuals should be treated as autonomous agents, but leading to a second and very important corollary, that those individuals with diminished autonomy must be protected. So we need to acknowledge autonomy. We also need to identify individuals with diminished autonomy. Beneficence is much easier. It's really do no harm. But in doing no harm, there are two aspects of that which are very important. One is that we should always strive to maximize the possible benefits of any research, and also minimize any possible harms that exist. So this is a responsibility that extends to individual investigators, but also society needs to understand that this is what we are doing. And again, you will notice that in the recent COVID pandemic, numerous treatments have been tried, sometimes with very little supporting scientific evidence, yet nonetheless the theoretical aspects of the treatment has been valid in all cases. Just because the treatment doesn't necessarily work does not invalidate either the scientific method that went into deciding upon its use, nor the compassion of the investigators who were investigating the trial. Justice is somewhat different, and it's something that we need to understand, because it's a question of who ought to receive the benefits of research, but also to bear its burdens. This is the question of justice in the sense of fairness in distribution or what is deserved. And therefore an injustice would occur when some benefit to which a person is entitled is denied for some reason or another. But we ought to receive the benefits of research and bear its burdens. In other words, clinical research needs to be very, very careful in terms of enrolling all appropriate patients to investigate clinical processes and procedures. Now, principles actually become rules, and we all understand the importance of institutional review boards, because respect for persons has now been translated into the necessity for informed consent. Beneficence means that part of that informed consent is to discuss risks and benefits, and also to indicate to our experimental partners how we are going to minimize risks. And as I've said, justice is a fair procedure to all selected research subjects. So what are the tensions and contradictions? Well, as I mentioned before, the old paradigm for ethics was protection, and it was really restrictive, and it was very, very difficult to perform clinical research in the setting of patient care. The new principle and the new paradigm of ethics is to obtain access to patients, but in an ethical manner. But now we come to the paradox of therapeutic misconception. And here, we need to understand that research should never be considered to be therapy. However, the paradox is that entry into a research project may lead to beneficial effects for the participants. So ethical principles are really statements of moral obligation from which rules, duties, or other principles are derived. Autonomy, the patient's right to have sovereignty over medical matters that pertain to their body. Beneficence, our obligation to pursue what is good for the patients. Non-maleficence, to avoid harm to the patient and to do everything to minimize harm. And justice, to treat all patients fairly and equitably. And certainly to provide fair distribution of medical resources. This has implications not only for subject enrollment in clinical trials, but for the practice of medicine in general. Our ethical dilemmas are increasing due to the increased sophistication of technology, limits on treatment, either by resource limitation or the fact that we have no further ability to treat. We have no more drug or medical devices to use. We have admission and discharge triage, which are becoming increasingly important, again, with limited resources. The importance of physician and patient relationships, which are traditional, but in the terms of COVID, with increasing isolation, early intubation, then relationships with families become very important, and the personal beliefs of the healthcare provider and stress among providers needs to be taken care of. So in SARS-CoV-2, or COVID-19 as it's commonly known, we have started talking about the determinants of futility, prediction of probability of adverse events. Not only do we now have advanced directives, but we have informed consent, and we also have informed assent as we start speaking with relatives of patients who are terminal, who cannot be there at the time of withdrawal or withholding life support, but are understanding that this may be a necessary discussion. And finally, we are looking at applicable state law and possibility. So the healthcare paradigm we work with today needs to be safe, effective, patient-centered, and timely. We're all familiar with this, but it also has to be efficient, equitable, socially responsible, and dependent upon outcomes. And that needs to drive the mechanisms by which we provide the care we give. There is no doubt that the scientific publications are becoming increasingly public. News media, social media are reporting results almost before the journals are able to provide insight. Preprint servers and newscasters on the nightly news have broken stories long before the scientific community has been ready. So the new reality includes greater public sophistication and interest in the outcome of medical processes, and we as physicians and healthcare providers must learn how to manage expectation against the reality of the care that we can give. There's no doubt that patient safety and a patient safety culture is increasingly important and has become a primary driver of care. It's fueled in part by news coverage. It's much more important that we as physicians understand that, yes, we work in dangerous environments and we cannot allow harm to come to our patients through misadventure that we should otherwise be able to prevent. So in summary, ethical issues are frequently present. In fact, they're always present during acute patient care interventions and as we stabilize patients. Ethical principles form the foundation of discussion, and each issue must be examined in the context of the principles we've discussed. Beneficence, non-maleficence, justice, etc. Analysis of medical facts and evolving psychosocial interfaces with ongoing communication will often lead to the resolution of the problems we face. And finally, the clinical research, evidence-based medicine, and compassionate patient care paradigms are always essential, and most importantly during the COVID pandemic. The final statement is that ethical considerations form the basis on which these precepts can be practiced and from which public trust and understanding are derived. They are the framework and the heartbeat of our profession, and it's been my privilege and pleasure to discuss some of these aspects with you this afternoon. Thank you very much for your attention. I wish you all safe passage and that we all have the opportunity to celebrate together in the near future. Thank you very much. Good afternoon.
Thank you very much, Professor Philippe. You are always, as well known, one of the pillars of the ECC for us for the last 15 years, and we are happy to see you virtually, and hopefully you'll be with us physically in the near future. We are starting our second session. My co-chair in this session moderating is Professor Ralph Hartung. It gives me a great pleasure to introduce our first speaker, Professor Asim Abdelrazak. And as I used to say, he is not only an old friend of mine, not old in age, by the way, he's very young in heart, but he is one of the pillars of our Emirates Critical Care Conference. He is Professor of Anesthesia and Intensive Care in Alexandria Faculty of Medicine. He is the Chairman of the Department of Critical Care in Alexandria Faculty of Medicine and Chairman of the Department of Anesthesia and ICU in Alexandria Faculty of Medicine. He will be talking to us today about COVID-19, who is at higher risk of serious symptoms. Professor Asim, the floor is yours.
Mr. Chairman, it's my rare privilege to be part of this conference. And in fact, I want to congratulate the organizing committee of making the impossible possible. Having this meeting on virtual and gathering all these speakers together is something fantastic, which I want to congratulate you. In fact, my talk today is something related to what we have at the moment, which is COVID-19. COVID-19 can affect anyone, but there is a higher prevalence of affecting people which are at high risk. And if you want to give you an opinion and just an imagination of what we have here in Egypt, we are one of the least country affected by COVID because of the strict regulation which we have applying here with the Ministry of Health. And you can see that the number of cases in Egypt was in the range of 112,000 cases until now, where the mortality rate is something like 5.8%. Which is high if you compare it to the rest of the countries, but this can be due with many people that does not go to the hospital in the proper time, and at certain times there was a lack in the number of beds available, especially in ICU for the critical cases. But now with the second wave, you can see that there is a second wave coming on, with many number of cases, but still it's under control. Now, there is many people who are at high risk of COVID and can be affected more than others. And the affection is more virulent when it is affected than the normal population. And this, namely, are people who have a chronic disease, as for example, cardiovascular diseases, which represent 10.5% of the cases admitted, diabetes mellitus, chronic respiratory disease, hypertension, and cancer. These are the overall. We have a plan in Egypt that, as in many parts of the world, that we divide the cases into mild, moderate, and severe. Mild cases usually are treated at home, but we guarantee that anyone having a chronic disease should be admitted to the hospital, and the people vulnerable to have super infection are admitted directly to the hospital and not waiting until they are classified as high. So immunodeficiency increase the risk of infection, and we know that the many cases which are having immunodeficiency as immunosuppressive drugs and people on chemotherapy, malnutrition, HIV or infectious disease, old age, genetic disease, metabolic disorder, these all people can lead to immunodeficiency and are more vulnerable to infection and the complication of infection as well. So we have conditions which are at high risk from severe illness, as for example, old people above 65, chronic lung disease, chronic kidney disease, COPD, heart conditions such as heart failure, coronary heart disease, and cardiomyopathy, especially people having an ejection fraction less than 30. These are very vulnerable people, which can lead to more complication when they are affected by COVID. So two things: these people are more vulnerable for infection, and if they are infected, they have a high virulent affection and they have an immunosuppressed state. Another categories of patients which are very vulnerable as well and lead to a high infection and high mortality rate is pregnancy, obesity, especially people having a body index, mass index of 30 or higher, sickle cell diseases, smoking, and type 2 diabetes mellitus. So the mortality rate with these people having a chronic illness is very high and higher than the normal population due to the impaired immune defense from both underlying disease and the treatments they receive. Immunocompromised patients with respiratory virus infection are at high risk of more severe infection and increased rate of bacterial fungal superinfection and leading to immunocompetent counterparts. So we have to take care of these people, and they have to be protected, and at the same time avoiding having the infection. But if they have the infection, we have to treat them vigorously from the beginning, avoiding any complication. So we have stage 1, stage 2, and stage 3, and this is a combination of two things, going hand in hand, antiviral response and the host infection response. And we have early infection, pulmonary phase infection, and hyper-inflammatory infection. Perhaps if we go further in detail, we can see that there is clinical symptoms for each stage of this stage, and we depend on this, depending on the clinical stage for having this classification. Usually there is clinical sign plus lymphopenia when we go to stage 1. Stage 2, there is an abnormal chest imaging, transmitted and low normal procalcitonin. But I have to tell you now, there is with the modification of the virus, we can see affection, but not typical infection. Sometimes the virus come, instead of coming to the respiratory, they come with gastrointestinal manifestation, and sometimes even in some of the mild or moderate cases, we get a phase of having no fever, but still they are positive to the virus. The most important, and with these people which we need to have focus on it, is the hyperinflammatory inflammation phase, which is stage 3. And this has to be treated usually in the ICU. And we have manifestation of RDS, shock, cardiac failure. And we have an elevated inflammatory markers, as for example, the most important, which start at the beginning, the D-dimer, the ferritin, and also the interleukin-6 and tumor necrosis factor. All these are the stages which happen, and we have to treat these patients very vigorously in the ICU, avoiding any further complication, because as I told you, these people having a chronic disease are more vulnerable for complication and mortality. So in summary, the excessive cytokine and chemokine caused by lethal coronavirus involve many antigens. The cytokines secreted by the immune cell are produced to eliminate the viral infection. So we have two reactions acting opposed each other. The viral response phase and the hyper-inflammatory cytokine storm. So the problem of the COVID-19 is the cytokine storm, which affect many organs, and especially the vital organ. So the cytokine storm is an activation cascade of an auto-amplifying cytokine. It triggers involved infection, malignancy, rheumatoid disease. So it is not only for the COVID, the cytokine storm, but it can happen anywhere, but it can be exaggerated with cytokine with the COVID-19. And here, there is something very important is to have an IgM response beginning in 5 to 10 days, and later on we have an IgG response. So the IgG response sometimes is later, but the presence of IgM and IgG meaning that the patient is in a very critical situation. So cytokine storm is a systemic inflammatory response to infection and drugs and lead to excessive activation of immune cell and generating a pro-inflammatory cytokine. Cytokine storm response is proportional to the chronic disease and chronic health. So people having a chronic health and having some of the disease which we discussed earlier, we can find that these people lead to some more complication and having affection and virulent infection of the virus. So the reason for this death, so cytokine storm can lead to death, is the cytokine storm syndrome. And there is a strong infection and having a strong complication, mainly cardiovascular and respiratory. So people having a vulnerable infection can have more complication, especially some depression of the immune system, represented by the cytokine storm, as well as the hemodynamic deterioration, as well as some of the respiratory. And these are the patients which we have to take care of in the ICU, and we have to admit them earlier in the ICU. What happens in the cytokine storm? In the cytokine storm, we have an early stage where there is interleukin 2, 6, and tumor necrosis factor appear, and it's very high. And at the same time, the cells start to adapt to the infection, but sometimes it fails for the adaptation which can happen. And here, we can find that the immune protection can fail, leading to inflammatory and inflammation damaging of the cell itself, leading to manifestation and aggravation of the signs and the symptoms. So the people which we need to take care of it are the asthmatic patient, so having a high degree of asthma, from moderate to severe, cerebrovascular disease affecting the blood vessel and the blood supply, cystic fibrosis, hypertension and high blood pressure, immunocompromised stage because of the weakness of the immune system, either from a bone marrow transplantation, they're having any disease, blood disease, immunodeficiency, and also people on a high corticosteroid level because of any causes, and they are treated by high corticosteroid. These are usually the corticosteroid lead to some affection of the immune system, and this can be a cause of having a virulent affection and virulent signs and symptoms of the COVID. So let's take one of the most of the important cases which can aggravate the infection. And the first one which I need to discuss with you is maternal symptom and pregnancy. So pregnant women are at increased risk of severe illness from the COVID-19 compared to the non-pregnant, and pregnant women with COVID-19 might have an increased risk of pregnancy adverse outcome such as preterm or eclampsia. Something very strange is the people they're having the high manifestation, which is representing fever, cough, and shortness of breath. These are the three manifestations which can happen with a patient having a pregnant woman having affection with COVID. There is some of the mild manifestation as headache, limb or joint pain, sore throat, diarrhea, and so on. But fever, cough, and breathlessness, these are the main manifestations which can be presented with a pregnant. But again here, if we take on this study, which is a CDC study, out of 38,000 women, the total number of deaths was 51 deaths because of the COVID. And very strange that the people who are high risk, we thought that this can be the people having the old gravid ladies, but in fact, the age vulnerable to high complication are between 25 and 29, sometimes 30 to 34. So these are the vulnerable age which pregnancy and can lead to complication. When we have people having a strong manifestation or a strong affection, a pregnant woman, the mortality rate is high. And we can see from these statistics that 287 patients was admitted to the ICU, 84 required mechanical ventilation, and the mortality of these people on mechanical ventilation in pregnant women was 60.7% in an international study. Diabetes also represents something very important to these people and leading to complication and manifestation. People having diabetes and catching the virulent virus COVID-19 can lead to very high complication, and the mortality rate is higher in comparison to the non-diabetic patient. So we need from the beginning to have some precaution for the diabetic patient, and they have to take the precaution of avoiding catching the infection to avoid any complication. Liver disease is also another severity, and the underlying liver disease is associated with increased risk of mortality in this category of people. In this study, where 2,780 people were enrolled in this study with chronic liver disease. The chronic liver disease mortality was 12%, and without liver disease is 4%. And you see, it's threefold. So people having pre-existing liver disease worsens the outcome threefold than the normal people having no liver disease. So the deaths occur 12% in patients with chronic liver disease without cirrhosis. But with cirrhosis, it goes up. So according to the PUF classification, we can see that cirrhosis class A mortality is 24% when they have with this cirrhosis COVID-19. So I'm talking about the combination of cirrhosis and COVID-19. So with class A mortality 24, class B 23, but it jumped to 63% when we reach the class 3 cirrhosis or the child PUF classification. So in another cohort study, including 152 patients with COVID-19 and chronic liver disease, 100 patients with cirrhosis. From the two international reporting, the mortality rate was 40%. You can imagine that it jumped to this number because of the people, they are very vulnerable of having infection, especially with those having liver disease. In a study of the same study, they found that the most common etiological among patients with chronic disease was non-alcoholic liver disease and non-alcoholic steatohepatitis. So in this group of analysis, there is a high risk of mortality of people having a combination of liver affection and COVID-19. So the mortality risk was not related to age, race, nicotine use, body mass index, hypertension, and diabetes. So it is the pre-existing, and these people, so the old age with liver disease are more vulnerable. People on nicotine use, cigarette smoking lead to more complication and mortality and morbidity higher. Obese patients with having a high body mass index, hypertension, and diabetes with the presence of chronic liver disease lead to very bad affection. So in observation study of 90 solid organ transplant recipients, you can see that the percent of these 30% had severe COVID defined as intensive care unit care mechanical ventilation. 46% had moderate COVID, and 24% had mild COVID. What happened to this patient? It's 16 deaths, 18% occur overall, and this usually happens in patients having a third category of people treated in the ICU. No risk factor for mortality, for example, the time from transplant, but they are more vulnerable to having complication. The study here, it has some limitation because of the small sample size and limit to the immunosuppressed patient. In this study, 111 long-term liver transplant survivors, 3 deaths. So you can see the death is almost 2.5% of the complication, but these are not the people having any complication after the liver transplant. But liver transplant per se can lead to more complication. COVID also is very susceptible in chronic obstructive pulmonary disease. And the mortality rate jumped to 8% with chronic respiratory disease, and leading to severe respiratory affection and having people needing mechanical ventilation when they are known people of having chronic obstructive disease. In this study, and which is an update review, discuss the available research regarding the implication of coronavirus in COPD. COPD is likely to increase susceptibility and increase the COVID severity, and specific mechanism to monitor and assess the COPD patients should be addressed in the current pandemic. So we have to focus on the patient having COPD, avoiding them of catching the infection by any means, and we have to treat them earlier, avoiding any complication, because the complication usually is lethal and lead to high mortality. So we have a good experience here in Egypt using the ECMO, and usually the ECMO is reserved to at least resort after failure of other strategy. The strategy which we use in COVID is lung protective ventilation, roll position, high PEEP, recruitment maneuver, neuromuscular blocking agent, and pulmonary vasodilator. If all these failed, we have to go to ECMO, and ECMO is used during the COVID pandemic, but we have to avoid, and we have to use it with people who are having a morbid obese people, severe immunocompromised state, advanced chronic systolic failure, and extrapulmonary resuscitation after cardiac arrest does not rapidly resolve with standard advanced cardiac life support. So usually when the people failed to the normal line of treatment, we go to have some ECMO, and the result which we have really with this type of patient are very promising. But it costs too much, and it is not found anywhere. It's found in the big cities and not in most of the cities. But when we use it, and our experience of using the ECMO, it leads to a very good result for these vulnerable people. So ECMO is contraindicated in patients with severe comorbidity, but it has, for example, multiple organ failure. So we don't put people on multiple organ failure, advanced malignancy, severe neurological disease, cardiac arrest for a prolonged period, and central nervous hemorrhage that is recently or expanded. So these people having this type of disease does not need ECMO, and it's a waste of time, waste of money of putting this type of people on the ECMO. So there is indication for ECMO as hypoxic failure due to cause when the pandemic mortality risk is more than 80, severe air leak syndrome, need for intubation with patient on lung transplant list, but it is contraindicated in very mechanical ventilation patient with a high setting, unwitnessed cardiac or respiratory arrest for a time which we don't know. So prolonged cardiac arrest is not an indication for having putting the patient on ECMO, even if the heart return. Disseminated malignancy, as I told you, CNS hemorrhage, and non-recoverable comorbidity after major CNS damage. From this, you can see that many people are very vulnerable of having more complication of having COVID, and these are the people which you need to focus on and avoiding to have the infection from the beginning, and also to treat them early and avoiding any mechanical ventilation or going to the ICU. If we protect this, we will have better results in this category of patient, and I would like to thank you for your attention.
Now I can. Okay, it works.
Now your voice is okay.
Yeah. Yes, good afternoon, good evening, all. Can you come down?
Maybe down.
Okay, it's better. Yeah. So it gives me great pleasure to introduce Professor Konrad Reinhardt. I think he has been here part of this conference from the very beginning. He is well known in the world as the sepsis guy. So he has been the founder, president of the global sepsis campaign, and I think it is self-explanatory that he will be talking about COVID-19 and sepsis. I'm very curious.
Dear colleagues and friends, it's my great pleasure to talk with you on the importance of recognizing severe COVID-19 as. These are my conflicts of interest. Since 2016, I'm a holder of 0.% of the shares of a Vienna-based company which currently conducts a study on COVID-19. What I would like to discuss is why it's important, as I said, to understand this relationship, why COVID-19 fulfills all the criteria for sepsis, and what the differences are between COVID-19 sepsis and sepsis from other causes, and I will address also the burden of sepsis and pandemics and the need to understand the synergies for cohesive infection management. In 2017, the WHO resolution pointed clearly out that most types of microorganisms, including viruses and including the coronavirus, may result, and these infections may progress to sepsis. In detail, they mentioned all the viruses like the influenza virus, the dengue virus, the swine flu, the avian flu virus, the Middle East respiratory viruses, and as I said, also the coronavirus and the Ebola and yellow fever viruses. In this resolution, it was also clearly communicated that it's necessary to communicate with patients and relatives and other parties using the term sepsis in order to enhance public awareness. And without this awareness, we will never get on equal footing with other diseases which are less common, like AIDS and others. Clearly, the Director General has made the point that in this context, that severe COVID-19 and other infectious diseases are at higher risk of develop and dying. And as you all know, the new consensus definitions made the point and defined sepsis as life-threatening organ dysfunction caused by dysregulated host response to infection, and that sepsis is a primary cause of death from infections, especially if not recognized and treated promptly. There are numerous studies that demonstrated in the meanwhile that also in COVID-19 infections and pneumonia, this infection may progress and cause organ dysfunction, which is measurable by what we call the SOFA score, and that this happens in about 60% for the lung, this damage, that it happens for the cardiocirculatory system, that it happens for the kidney in terms of kidney damage, but also that COVID-19, as all other forms of sepsis, are associated with severe disseminated intravascular coagulation and the consequent complications. In the meanwhile, this has been acknowledged in quite a number of journals, not always called sepsis, but in this case, extrapulmonary manifestations of COVID-19, but this fully complies with the understanding of sepsis. And among the first publications on these topics from China, these colleagues made this point and even could demonstrate that the signs of organ dysfunctions may appear even a day before, for example, the appearance of acute respiratory distress. To summarize the similarities in terms of the emergency warning signs for patients and also who is at risk for sepsis and COVID-19, and also who has long-term sequelae. If you look at this, you will find that there's no difference in this respect between viral and bacterial sepsis. This also holds true of the organ damage, and most laboratory abnormalities that we know of from bacterial but also viral sepsis are quite similar. There are, as this is not only the case for COVID-19, but also, for example, meningitis or cholera or malaria-induced sepsis has different features. And in case of COVID-19, this is, for example, the sense of taste, loss of taste or smell, persistent discomfort or pressure in the chest. Also the fact that pregnant people and people with obesity are more susceptible for COVID-19. Perhaps fatigue syndrome and headache and loss of sense and smell are more common also in terms of long-term sequelae of COVID-19, and perhaps, but not for sure, also venous thrombolytic events, pulmonary embolisms and stroke and myocardial infarctions may be more common, but we need to. We all know that the current pandemic is the worst pandemic since we have experienced the so-called Spanish flu, which appeared in the US in 1918, and until 2020 globally, it affected millions, hundreds of millions of people, and of whom at least 50 million died. This was at this time 3% of the global population. And these people died by hypoxia, but it was also recognized already there that sepsis and septic shock are common features, but there was no big chance because there was no critical care medicine and intensive care medicine available to support the organ dysfunctions and to overcome. This makes a difference for nowadays, and what is also very interesting that although the cause of this flu, of course, was the influenza virus, in this case, super infection with bacterial infections was the case in most all of patients with severe forms of the so-called Spanish flu. And the reason for this is that this virus makes the epithelium of the lung more susceptible for bacterial invasion. Clearly, this is different with SARS-CoV. Clearly, this is different with SARS-CoV-2. It's really a more specific viral sepsis where secondary infections by bacteria occur less. And this, for example, there are a number of studies where you can see that the incidence of secondary infections are only in the range between 15 and 50%. Of course, nowadays we have understood much more on the pathophysiology, especially from COVID-19, and it's not, and there are clearly also direct cytotoxic effects by the virus, and there is dysregulation in this case also from the renin-angiotensin mechanism, but which also may be dysregulated in bacterial sepsis, and sepsis from COVID-19 is considered also as a disease which addresses the endothelium, and of course, which causes a dysregulated immune response. So we have more understanding, but what still became clear to the fact and confirms what Sir William Osler has said already in 1896, that by far the greatest enemy of mankind in comparison to famine and war is fever, a synonym in this case, sepsis. And this has been confirmed by a recent publication by the authors of the Global Burden of Disease report, which was supported by representatives of the International Sepsis Forum and mostly also by the Global Sepsis Alliance. And these are staggering numbers, almost 50 million cases in 2017, which went along with 11 million deaths, which means about 20% of all global deaths. And of course, not surprisingly, the incidence per 100,000 population is much higher in the poorest regions of the world. And interestingly, these are the data from the Eastern Mediterranean region, which most of you may interest also. And this report came up with an estimate of 2.8 million cases and almost 1 million deaths, and probably because of under-documentation of infectious diseases and death in the death certificates, this number may be underestimated. That's why on this occasion I would like to encourage also to follow up and to join the European, not the European, but the Eastern Mediterranean Sepsis Alliance and Sepsis Alliance. And the number, if you compare them in our times to the numbers of this and the perception of William Osler more than 100 years ago, you see that with 11 million deaths in 2017, sepsis is more common, like, for example, cancer with 9.6 million, and clearly also with HIV, and clearly also on the annual number of deaths by war. And when you look on this graph from the dashboard of the Johns Hopkins University, we currently have more than 58 million cases, but less deaths compared to the Spanish flu with 1.3 million. And this is due to the fact that we have, of course, at least in some parts of the world, adequate intensive care resources and also more and more medicines that might help. But the burden for the world is tremendously. This is a recent estimates that only in the US the COVID-19 pandemic may cause costs of 16 trillion US dollars, which is 90% of the annual gross domestic product of the United States. So it's a problem. And this problem adds, and these numbers on deaths from COVID-19 add to the number of 270,000 annual deaths by COVID-19, which cause annual deaths by sepsis, which make cost for the US healthcare system in the range of 62 billion US annually. And that's why the notion that, which was expressed by some Surgeon Generals and other health leaders, that the book of infectious diseases can now be ultimately closed by the great achievements, especially in countries like the US, high-income countries between 1900 and 1950, by measures like chlorination of water, penicillin, vaccination, etc., only interrupted by the so-called Spanish flu, as you may depict by this spike. And indeed, we have better understood now that infectious diseases and sepsis can be prevented by vaccination, clean care, early recognition, and treatment as emergency. And there is interesting data to confirm that it is possible not only to, with the current measures that have been taken in quite a number or in most countries which are inflicted by COVID-19 in terms of distance, social distancing, in terms of wearing masks, in terms of even to taking measures which severely impairs human rights and the economy. But what these authors, which is a group who collects pathogens that may cause invasive bacterial infections, and they found a significant decrease of pathogens like Streptococcus pneumonia and others after taking these measures in every country. This is for the countries that participate, and they concluded that their data demonstrate significant reduction in invasive diseases caused by bacterial pathogens that are like SARS-CoV-2 transmitted via the respiratory route. So, and they say that the most plausible explanation for this was the interruption of person-to-person bacterial respiratory transmission. So this means we can also learn from this of measures, and we can also learn that what I mentioned earlier, that on the role of the host response, which was also recognized by William Osler, who realized that except on few occasions, the patient seems to die from the body's response to infection rather than from it. And we have tried over 2 decades now to intervene the immune system, and most of these trials failed. But as you all know, the trial conducted in the US with in UK on dexamethasone in COVID-19 was quite encouraging, and this was confirmed also by a recent meta-analysis. The authors of this came to the conclusion that administration of systemic corticosteroids may reduce mortality. And there's increasing understanding that also, for example, the innate immune system characterized by the complement factors and blocking these may be helpful, and there are a numbers of studies going on. Them are already published in this trial with an antibody against C-CIF-A. Despite very small numbers, there were significant differences on the impact in comparison to a placebo group, for example, in the glomerular filtration rate and creatinine levels. There was a faster decrease in lactate despite only 16 patients in each group compared to placebo. And interestingly, there was also a significant faster increase in dimers in the treatment group, probably signaling a faster resolution of microthrombi or other thrombi. And these findings were summarized that there is, and encouraged this company to move forward phase 3 trial. And there's also an encouraging comment by editor. And also this recently published a study by Charlie Anand's study group in France with an antibody against C5 is encouraging because they found also a significant difference. This was not a randomized trial, but a before and after study. but this went along in those who use this antibody, which blocks the membrane attack complex. And this was associated with a higher incidence of ventilator-associated pneumonia with 50% compared to only 24% in the placebo group. And there was also more bacteremia in this group. So what we have learned that, and what we ask for, that the fight against sepsis requires the same vigor and passion as the fight against COVID-19, and we must encourage policymakers and everybody, all other stakeholders, and there's progress, as you know. There are now probably effective vaccines that need now to be made available on a global scale. We should work hard to get access to critical care in every country, and to guarantee and improve our lab capacity in the facilities, etc. And we can learn also what from the conclusions that have been taken in an article published in Science in 1920, that the great lessons of the pandemic is to call attention to the prevalence of respiratory diseases in ordinary times, to the indifference with which they are ordinarily regarded, and this indifference over too long a time has been the case towards sepsis, and what we need to do there to address this number one cause of. So if I can only encourage you to join this fight, and if we do so, we will make major contributions also to the achievement of the sustainable development goals and save lives of millions of our civil society all over the globe. Thank you.
So you take it? Yeah. You're not expecting me. Thank you very much, Professor Reinhardt. We now move to our next presentation. Our speaker for the presentation is Dr. Dirar Abdullah. He is the chair of medical and the intensive care department in Prime Hospital. And he will be talking to us about one of my favorite topics, empirical antibiotics in COVID-19. What did we learn? I hope we did learn something. Dr. Dirar?
Inshallah. Thank you, Dr. Ashraf. Assalamu alaikum, everyone. It's my pleasure to be here, of course, at this hybrid conference and to visit physically conference rooms. Today I'll be talking about we're going to talk about antibiotics used in COVID, our experience, and in general the evidence behind to support the use of antibiotics or not in COVID-19 patients. So these are my learning objectives, which I will go through. To make it a kind of interactive with our audience, we have, mashallah, great audience online, of course, much more. I'm going to present this case whom we managed in our hospital, a 51-year-old male patient who's known case of diabetes, hypertension, hyperlipidemia, and ischemic heart disease. He was non-smoker. He came with a respiratory distress, dry cough, fever, and he was having low oxygen saturation. His RR was 24, and he came with a COVID positive result from the beginning. His procalcitonin was negative. It was 0.07, WBC 7,000 with 13% lymphocytic count, and his C-reactive protein was 70. He was admitted to the ward, not to the ICU, and he was started on oxygen 5 liters per minute with a saturation of 96%. So the question to our audience, would you start antibiotic for such patient or not, based on what you have done before and not based on what we learned already? And please, you can type your answer in the chat box, and I'm going to kindly ask our moderators if they can just have an idea from the trend of answers, whether yes or no. At the end of the presentation, inshallah, we'll come with a percentage of answers, who will start antibiotic for this patient and who will not start antibiotic.
The answer in different boxes.
So it's not moving. You will start? You will not start antibiotic. Okay, let's see the general trend. Yeah, I know you are experienced intensivist and you know that you should not start it. But let's see our audience. This one, the pointer is not working. Can you move it from you to the next slide, please? Yes. So that was the question actually, which we asked. To type your answer whether yes, A, or no, B, or you are not sure, or D, you will start because you are not sure. Start by, until the slides are ready, by saying that there are general international guidelines, whether by WHO or by different countries who developed guidelines to treat COVID-19 patients. And when it comes to WHO, we know that the general advice from them and the official advice was not to start antibiotic for mild COVID-19 cases, and to start it for the moderate cases only if with certain conditions, like people in long-term care facilities or children less than 5 years. And they specifically said to start access antibiotics like amoxicillin, clavulanic acid, or other narrower spectrum antibiotics. For severe cases, the WHO, they advise that we should start antibiotic, again, based on a clinical suspicion, epidemiological factors, severity of the disease, and to start it as soon as possible when the patient is presenting in a critical condition. Also, other countries in the world like China, Italy, Germany, they mentioned clearly that severely ill patients, you should consider starting antibiotics if clinically indicated, and for mild cases or moderate cases, we should not start any antibiotic at all for the patient, because mostly it is not going to respond. No, still it's not. This will give time for our audience to have more answers regarding our questions until the technical issue is resolved. Okay, thank you. So from previous experiences, we know that the rate of bacterial co-infection, for example, with severe influenza, it can reach up to 30%. It is associated with a greater severity of illness, with the great use of healthcare resources, and with worse outcome. WHO, we spoke about their advice in regard to the starting the antibiotics. Only they indicated for severe COVID patients, empirical antibiotic has to be started according to the clinical judgment, patient host factors, and it should be assessed daily for the escalation. General guidelines all over the world, they said the same. Only if it is severe or clinically indicated, we can consider, not to start, we can consider starting antibiotics. NICE guidelines from UK, they said it's reasonable not to start the antibiotics for mild cases, again, because generally it's a viral disease, and only if it's clinically suspected, plus high neutrophils and lower pattern of pneumonia, at that time you can consider. It has to be started within 4 hours, antibiotics for the patient if decided to start it, and 1 hour if the patient is septic. And they did not advise to do microbiological or to wait for the microbiological test results. They even determined which antibiotics we need to use for cases of hospital-acquired pneumonia, like doxycycline, coamoxiclav, or clarithromycin, and once it's severe, levofloxacin. And also, they recommended for hospital-acquired pneumonia, if the patient can take orally, to start the same antibiotics, almost, with the addition of cotrimoxazole. But if the condition is severe, to start piperacillin, tazobactam, or ceftazidime, and then to add MRSA according to the clinical judgment. In UAE, the last version of our national guidelines advise officially against the use of antibiotics and to adhere to antimicrobial stewardship principles. Although earlier in the year, in March, with the first version, the advice was to start it only for severely ill patients, for ICU cases, and it was mentioned specifically which antibiotics they suggested that we can consider starting for severe cases. IDSA generally, they don't recommend or not recommend, they just states that it is a viral infection, that using antibiotics can cause, can increase the antimicrobial resistance. So, and they quoted so many articles done earlier in the course of COVID-19 pandemic talking about high use of antibiotics for COVID-19 patients. In general, there are so many studies, of course, regarding the bacterial co-infection. I'm quoting these two studies earlier at the pandemic, reporting high use of antibiotics, but at the same time, high use of bacterial co-infection. In Zhu and colleagues, they reported around 15% of bacterial co-infection, which is not a low percentage. 50% in autopsy found to have bacterial infection in the non-survivals. And the second study by Fink and colleagues, they found around 35% of bacterial co-infection in critically ill patients. And all of the studies are talking about high rate of using antibiotics for COVID-19, 70%, 80%. But at the same time, these studies reported very low rate of bacterial co-infection, which is maximum was 8 or 9%. So most of the studies talking about less than 10% co-infection rate. This is a multi-hospital cohort study with a large number of COVID-19 patients from Michigan, where they found that more than 50% of the patients treated with antibiotic. Yes, and they analyzed even the procalcitonin level to find that around 50% of these patients have high procalcitonin. And they found a large variation between hospitals from 27% to 84%. They concluded from this study and other studies that bacterial infection is more likely if the patient is elderly, in children, if they have any comorbidities, specifically kidney disease, if the patient is coming from long-term facilities, or critical patients admitted to ICU with a high W blood cell count and high procalcitonin, which was found in more than 50% of the cases in the ICU. This is an international web-based survey to investigate the antibiotic prescription practices in patients with COVID-19 with 166 participants from 23 countries by the Infectious Disease International Research Initiative, which I am part of. The responders were infectious disease in 50%, intensivist in 29%, and internal medicine 11%. They want to know their opinions regarding the use of antibiotics with COVID-19, and there were answers. 62% said they are following the local guidelines for antibiotic usage. The main determinant for starting the antibiotic was the clinical presentation, followed by the lab parameters. They tend to cover atypical pathogens, followed by Staph aureus and then Pseudomonas. Around 30% will not start antibiotic in the ward. And usually, the preferable antibiotic was a combination of beta-lactams and macrolides or fluoroquinolones, more than 50%. In ICU, it is typical piperacillin tazobactam was the most commonly prescribed antibiotic, and the mean duration was 7 days. In our hospital, we did some analysis on cases of COVID-19 admitted to the ward. We found very less percentage of them having high procalcitonin. And in patients who are admitted to ICU, we found around 2/3 of them having high procalcitonin. We just want to find any correlation and to learn from our data for the future. God forbids if we are facing another wave. So we presented our data to the ICVID conference, which is the ESCMID conference on coronavirus disease, about the trends of using antibiotics during the pandemic from March to June 2020, and we compared it to the same period of last year. Because, you know, prescription of antibiotic here, it's seasonal. And we found a huge increase in using meropenem, but not ertapenem, with using piperacillin tazobactam and levofloxacin, more than 100%. Ceftriaxone also, ceftriaxone, it was decreased, which indicates a trend of using more broad-spectrum antibiotic. Cefazolin was not changed because it's our preferred antibiotic as per the guidelines for surgical prophylaxis. Anti-MRSA antibiotics also, they were increased significantly during the first wave. So what could be the reasons why of this misuse and overuse of antibiotic, I will say, during the pandemic? Because the stewardship, not everyone have antibiotic stewardship program. And even hospitals with antibiotic stewardship program, they were forcefully put on hold, either because of the team was very busy treating and dealing with COVID patients, or because of using the antibiotics widely, and the teams were busy with such pandemic. Cultures were rarely utilized for the patients who are admitted because the dry nature of the cough and because of fears of aerosol infection, and this applied on us as well, where we rarely did cultures for our patient. There were lots of misinformation in the social media about using antibiotics and the bacterial infection as a main component of COVID-19, which unfortunately even some of the medical staff they were affected with, and they were starting antibiotics even for mild cases based on these. And there is the common reason, which is just in case, I don't want to take any risk. So we concluded from these that the majority of COVID-19 patients may not require antibiotics empirically. But we also knew that secondary bacterial infections and co-infections were significantly associated with worse outcomes. And the overall proportion of COVID-19 patients with bacterial co-infection is low, less than 10%, but in critically ill patients, it is much more than this, 35 to 50% according to two studies I presented earlier. And it is affected, of course, by the severity of COVID-19. So what we need to do now, we need to learn from this experience. We need to collect data from our institutions. We need to utilize more diagnostic testing, fast COVID-19 turnaround time, because initially at the beginning of the pandemic, we all remember that it was taking around 5 days, 4 days, 6 days for the result to be there, for which the physicians were starting antibiotics waiting for the COVID-19 result. Nowadays, we have it in less than 1 day. So we can decide whether it is a COVID or not. We should utilize procalcitonin, although the evidence is insufficient and the threshold is uncertain, but its negative predictive value is high. It can reach to 98% for bacteremia and 82% for severe community-acquired pneumonia. We should again send stewardship into life with COVID-19 after we had some time to breathe, especially here in UAE. And we have to consider antibiotics for critically ill patients, of course, based on the clinical judgment, compared to our patients where our data, international data, showed that the rate of bacterial co-infection of procalcitonin was very low. So, in conclusion, should we start an antibiotic for COVID-19 patient if the patient is elderly or a child less than 5 years of age, if the patient is having kidney disease or coming from long-term facility, or a critical patient in the ICU with high W blood cell and neutrophilic count and procalcitonin? Or should we use a combination of these factors to make our decision to start antibiotic? And should we avoid it in mild and moderate cases with a younger patient and no clinical evidence of bacterial pneumonia without lobar involvement, with a chest image which is typical of COVID-19 and normal procalcitonin and neutrophilic count? If there is lymphopenia, which indicates, again, COVID-19, and if the microbiology is negative, although that does not rule out completely, or again, we should use a combination of these factors to decide not to start antibiotic for COVID-19 patients. So we faced a lot of challenges to stewardship. We are still facing it. I spoke about them earlier. And so now it is the time to breathe. What we have learned is that you should collect your own data and you should come up with some conclusion. Plan future ASP intervention according to your own data to see how many patients received antibiotics, how many patients developed bacterial co-infection or fungal co-infection, how many of them had high procalcitonin or not. This is what we did in our hospital. And identify the factors that put your patient or COVID-19 patient at risk for those infections. And looking into the future, we should utilize the information technology more effectively because it is the future, especially with these situations where we don't know when the social distancing will end. It's not nearby. So the ASP team has to adapt on online meetings. It has to find another way of education. We should utilize more diagnostic, although it is challenging in some hospitals, like procalcitonin, urinary antigens, respiratory viral panel. And we should develop or have some antimicrobial guidelines specific for COVID-19 patients. And the big question will remain after this pandemic, which is still ongoing, whether the AMR will increase post-COVID or not. There are some people arguing that it will increase because of the overuse of antibiotic, which is the classical cause. Because of some COVID-19 centers, they developed some MDR outbreaks, and using some medications like steroids and tocilizumab, which reduces the immunity and develop more secondary bacterial infection. But others are arguing that the AMR, maybe it will not be affected or decreased because of the overall use of antibiotics in humans. They decrease significantly. In one large study in the United States, they found 30 to 40% reduction in antibiotic usage. And because of the restrictions, so less travel, social distancing, masks, less spread of infection, and then COVID-19 precautions with less influenza and less antibiotics. So we don't know the answer. We are going to see it in the near future, inshallah. At the end, we need to remember always the ASP principle, which is to review your antibiotic on a daily basis, to de-escalate shorter courses of antibiotics, switch from IV to oral after 48 hours whenever it is possible. So back to our patient whom we had the question about regarding the antibiotics usage. We're going to kindly ask Dr. Ashraf, our moderators, to give us some clue about the answers of our audience. How many of them answered yes and how many answered no, or a rough percentage?
Majority, yes.
Majority, yes, yes. That was actually expected. And this is what we are intending to change actually after this presentation and presenting these data, at least for mild cases and moderate cases admitted in the ward, where at the second phase of the first pandemic, even for us in the hospital, we stopped using antibiotics for the patients in the ward at least. For the ICU, we continue to use them. Although this patient, we started him at that time on piperacillin tazobactam, moxifloxacin, and we added vancomycin later on when we shifted him to ICU. We are not exception, actually. So, but we hope this majority will become a minority in the future based on these lessons we learned and the data we presented today. Our patient improved, he was ventilated, then extubated, and improved later on. So these are my references, and thank you very much.
Yeah. Thank you very much. Can we ask you to stay in the room to answer the questions after the last presentation? Yeah, because we certainly will have some questions. So the last presenter in this series is Professor Farid Zand. He comes from a place not far from the UAE. It is from the southern parts of Iran, from Shiraz, and he will be talking about which one will save more lives in the pandemic, the vaccines, the medication, or the critical care.
Good evening, everybody. I'm Dr. Zand, working in Shiraz University of Medical Science, and I want to share my slides with you about role of vaccine, medications, and critical care in this pandemic. This is Namazi Hospital, where I work in south of Iran, Shiraz, and this is my disclosures. I have no relevant conflict of interest regarding this talk. I want to quickly review the COVID-19 mortality, role of different interventions to decrease mortality, like vaccine, medications, critical care team, and the future hopes and challenges. As you know, SARS-CoV-2 may cause severe respiratory disease and fatalities in humans. So estimating the fatality plays a key role in understanding this pandemic and guides appropriate responses and efficient strategies. According to WHO statistics, up to November 24th, more than 58 million confirmed cases have been reported to WHO, and this includes 1.4 million of deaths. But is this death rate true? The true level of mortality is frequently underestimated. This is because the neglected cases or underserved segments of population are usually not included in this statistic, and testing capacity may be limited to severe cases or some populations of the community, like healthcare workers, and cases may also be misdiagnosed with other diseases like influenza. We usually, when we speak about mortality, usually hear two terms, case fatality rate and infection fatality rate or ratio. And what is the difference between these two? Case fatality rate is the proportion of deaths among a certain disease compared to the total number of diagnosed cases. So if we divide the number of deaths from a disease on the number of confirmed cases, the number that we have is the case fatality rate. The case fatality rate differs between different countries. The highest rate has been reported from Yemen. It is about 29%, and the lowest is reported from Singapore with 0.05%. The global case fatality rate for COVID-19 is 4.34, that is reported by WHO. This variability in case fatality rate is likely due to the testing frequency and differences between health system capacity between different countries. But what is infection fatality ratio? The infection fatality ratio represents the proportion of infection among all infected individuals, including all asymptomatic and undiagnosed subjects. So the infection fatality rate differs from case fatality rate in that it aims to estimate the fatality rate in both sick and healthy infected, which are asymptomatic and not tested groups. According to a study conducted by Empirical College of London and published in October 2020, after screening 175 serology test studies, the estimated global infection fatality rate for COVID-19 has been reported about 1.15%, and it differs between high-income and low-income countries. And surprisingly, the countries with low income has lower infection fatality rates, which is about 0.20. And this difference is because of the difference in the population, and the population who are more aged and older have higher infection fatality rates. This is in contrast to case fatality rate, which is usually more in low-income populations. This is a table that you can see the countries that the report has been from. It includes Brazil, Denmark, UK, Italy, Netherlands, some United States, some states of United States of America, Sweden, and other countries. The infection fatality rate is a better estimate of population mortality. In a report from 51 locations, median of infection fatality rate has been, was about 1.15, and the range was between near 0 to 1.54. The study was from WHO and was published in October 2020. The infection fatality rate was about 0.1 in the locations with COVID-19 population's mortality rate less than the global average, like United Arab Emirates. And the infection fatality rate was about 0.2% in locations with moderate deaths per million, like Canada, and it was 0.57 in locations like United States, who have high rates of mortality in deaths per million. This is the centers that has been included in this study. If infection fatality rate is about 0.57 in US, then how many people has been infected in this country? As of November 23rd, the confirmed report cases of COVID-19 has been 250,000 in the United States. So if you want to estimate the infected people in the United States, we should divide this number on 0.57, which is about 45 million people, which is roughly about 14% of the population. So even in the US, with the highest reported infection and mortalities, we are extremely far from herd immunity. Most models show that the herd immunity threshold for COVID-19 will be close to 16 to 70%. And according to WHO position on herd immunity, it is not scientific and problematic and unethical to let the people get COVID-19, letting them to get COVID-19 to reach to a herd immunity. It causes unnecessary infections, suffering, and death. So we need a vaccine. There have been difficulties in the development of coronavirus vaccines historically. Coronavirus vaccine in animal models has caused immunogenicity, but generally not shown to have to effectively prevent acquisition of disease. The S protein of the virus is the target for making vaccines, and herd immunity. So, as herd immunity is unethical and far from our scope, the safest way for effective and sustainable prevention of COVID-19 is to have an efficacious and safe vaccine, and the majority of the population should be successfully vaccinated. But could a COVID vaccine bring back normality? As we know, Pfizer and Moderna has introduced vaccines, and they project that they can provide 35 million doses of vaccine in 2020, and they can provide 1 billion in 2021. As a result, many millions of people at high risk of disease will not be immunized anytime soon. Unfortunately, the trial results were released by press, leaving many uncertainties. Little safety data are available. We don't know how well the vaccine works in older people or those with underlying conditions, and we don't know the duration of protection. Whether the vaccine prevents transmission or just protect against illness is largely unknown. If so, achieving herd immunity through immunization becomes a difficult prospect. Also, there is a danger that the public might become complacent about the news of vaccine. How much difficult will it be to ensure adherence to restrictions if vaccine is available to many but others remain unprotected? Vaccine hesitancy is also a clear threat to COVID-19 control, and responsible leadership and careful public communication will be essential. The other problem is expensive cold chain requirements that we need for providing the vaccine to different nations. COVAX financing mechanism to provide COVID vaccine to low-income and middle-income countries has raised $2 billion, but needs $5 more billion for 2021. Another problem is that Pfizer and Moderna have not yet reached agreement with COVAX to supply vaccines, although some vaccine developers have promised to limit profits from the COVID-19 pandemic, but Pfizer and Moderna have made no such commitments. What about the medications? During a pandemic, repurposing or repositioning available therapeutics is the fastest way to manage a pandemic. Antiviral therapies are among the most used drugs during this pandemic. These drugs has the greatest impact when the disease is in the first phase. It is will be for later stages of disease, including critical illness has begun. There are different mechanisms for action of antivirals. The most famous one is remdesivir. Remdesivir, a nucleotide prodrug of the adenosine analog, binds to viral RNA polymerase by inhibiting replication, has demonstrated in vitro activity against SARS-CoV-2, approved by FDA for the treatment of COVID-19 in hospitalized adult and pediatric patients more than 12 years of age, has been studied in several clinical trials for the treatment of COVID-19. The first one is published in Lancet in April, and the result was unfortunately not very convincing. And there was unfortunately, there was no difference between the two limbs of randomized double-blind control trial, multi-center trial in China. And the authors report no significant difference in clinic and no significant clinical benefits by remdesivir. The second one is published in JAMA in August, and the authors looked at the effect of remdesivir versus a standard care on clinical status at day 11. The study was again negative, and the authors did not have a statistically significant difference in clinical outcomes. The most important and the most recent one is the ACT-1 study done by United Kingdom colleagues, published, the final version is published in October 9. In this study, remdesivir was compared with the standard care. The patients were divided into different groups. The patients who were admitted in hospital and taking no oxygen, taking just oxygen, taking non-invasive ventilation, and invasive mechanical ventilation. Regarding time to recovery, the only subgroup with most benefit was the patient who just received oxygen. There was no significant difference between the patients who received high flow nasal oxygen and non-invasive ventilation and the patients who received mechanical ventilation. So the only significant difference was seen in mortality at day 15 in the patients who was admitted in hospital and take just oxygen. The groups with non-invasive or invasive ventilation had no difference. And this is another systematic review published in October in Annals of Internal Medicine. In this systematic review, the authors recommend that the remdesivir may reduce mortality, but the limitations of this study is low certainty evidence with few published trials. And the most recent news is the trial by WHO called Solidarity Trial, that the link with remdesivir had no significant difference with placebo. And another problem is that remdesivir is an expensive drug. The course of treatment in hospitalized patients cost about £2,000, which is a huge amount in developing countries. And the last news about remdesivir is it comes from European Society of Intensive Care Medicine, who is going to advise against use of remdesivir in sickest critically ill patients. And what about dexamethasone? Dexamethasone is used in recovery study, and a study was published in July by a group from United Kingdom. They included 6,400 patients, and 28-day mortality was significantly lower in the patients who received dexamethasone compared to the standard of care. So they concluded that receiving either in invasive mechanically ventilated patients, dexamethasone could reduce mortality. And this is another systematic review. comparing all drugs that has been used in treatment of COVID-19 patients, published in British Medical Journal in September, including 25 high-quality RCTs. The result is that glucocorticoids probably reduce death rate by about 3%, which is a huge amount, and it means saving more than 30,000 lives when mortality is 1 million. But the impact of remdesivir on mortality is uncertain in this systematic review. And this is a table about the recommendations of National Institute of Health for COVID-19 patients. As you see, a lot of recommendations is against use of these drugs. And what about critical care? Critical care in COVID patients means oxygen therapy, ventilator support, hemodynamic support, acute kidney injury and renal replacement therapy, pharmacologic interventions, and competent intensivists. Of how we can estimate the impact of critical care. One way is to look into the relationship between availability of care services and mortality in different health facilities. In a publication in the Intensive Care Medicine Journal, the authors looked at the differences in 14 European countries about accessibility of intensive care. They defined an index called Accessibility Index, and they found that the accessibility index to critical care in these 14 countries is quite different between countries. And they concluded that lower accessibility of intensive care is associated with higher COVID-19 case fatality ratios, and some countries like Germany are particularly well positioned to manage a swift increased need for intensive care, whereas others like Denmark, Italy, and Sweden have lower numbers of intensive care beds. Another way to estimate the impact of improved critical care is to look at the trend of COVID case fatality rate in previous months. This is a publication about declining COVID-19 case fatality rates across all ages in Germany. And as you see, during a 3 to 4 months period, the fatality rate of COVID-19 has been declined, and the more profound effect is in the group with older age. This 2% decrease in the trend of mortality during 3 to 4 months period, even before any effective medication was proposed by Act 1 and recovery studies, may be due to better critical care. And what is the role of intensivists? Many COVID-19 patients meet consensus criteria for ARDS. The particular difference noted in COVID-19 patients is unusually high levels of respiratory compliance and increase in dead space. Key differences between COVID-19 pneumonia and ARDS that COVID-19 patients will occupy their own unique space under the ARDS umbrella. So why the intensivist so important? Our ability to determine where on the spectrum of disease a given case of COVID-19 lies is problematic. Thus, while we await in-depth studies, it seems appropriate to apply a standard of care to those COVID-19 patients whose pulmonary pathophysiology is consistent with that disorder. However, reliance on thoughtful bedside observation and physiologic understanding of which is the essence of intensive care practice, is essential. And in the conclusion, 2020 has been a year of incredible scientific achievements. In less than 20 months, researchers have characterized a novel illness, sequenced a new virus genome, developed diagnostics, produced treatment protocols, established the efficacy of drugs and vaccines in randomized controlled trials. But critical care team started to save lives at the outset and continues to do so until the last patient needs help. May God bless them and keep them safe. Many people are feeling hopeful for the first time in this long time, but there is still much to learn and many barriers to overcome. It is a dangerous moment to complacence. This is not a competition, it's like a relay race, but it seems that critical care team has to have during all the path. Thank you very much for your attention, and I'm here for any comments or questions.
Thank you very much, Dr. Farid, for this nice presentation. I think we still have 5 minutes to have some questions. I know we are running very late behind our time, but there is some questions which came to us particularly related to the use of antibiotic, probably because Dr. Dirar did pose certain questions and he invited some interactive results. Dr. Dirar, do you think, please can you come to the podium? Do you think the confusion between the term co-infection and super-infection participated in the way of we are using an antibiotic? Now, when we are talking about empirically starting an antibiotic to someone who's coming with lung infiltrate, we are assuming that there is a bacterial co-infection. But when we are talking about a patient who stayed on the ventilator for a week or 10 days, then he started to develop signs of bacterial infection. We call this super infection. Now, all the definitions which is being said was about co-infection. Co-infection, this really the reason why we start empiric antibiotic?
Yes, I believe the contribution of this reason, if there is any such reason, is very low, which is concerned about. Actually, my topic did not cover super infections or secondary infections. It covers only co-infection, and most of these studies are talking about the rate of bacterial co-infection. Some minority of the studies, they studied co-infection and secondary bacterial infection in one conclusion. But the trend to use antibiotic was not based on bacterial co-infection at the beginning, I'm saying, or secondary infection, because secondary infection, we in the ICU only will be able to diagnose and will be able to start the antibiotic. Our topic covers the empirical use in cases admitted either to the ward or to the ICU. And most of the people, they are starting it for this particular indication. Now we learn that the bacterial co-infection rate, not secondary, is less than 10% overall for the patients, but it is much higher for critical patients and much less for ward cases.
Yeah.
Sorry?
That's the idea. The main idea is the confusion between the term co-infection and super infection is what created the requirement of giving everybody you suspect of having bacterial infection those antibiotics. So we can understand that if somebody is suspected to have a bacterial infection, you will start an empiric antibiotic because this is by definition the standard practice. But we need to know if you send a biomarker and your cultures and certain investigation and you don't have an evidence of infection, the people are still using it because they feel that the co-infection is important.
Yes, and this is what we need to stop. The reason, just in case, or to be on the safe side, it has a major contribution actually in deciding when to why to start the antibiotic. And we know this from our practice. You know with Dr. Ashraf much better than me. You are much more experienced than me in your ICU. This is what we are planning to reduce, the empirical use just in case. And we are planning to educate not only the public now, we are planning to educate some of the healthcare professionals who think even mild cases and who are advising to start antibiotics for mild cases of COVID-19.
Quickly, because we don't want to prolong this, somebody asked you about pregnant ladies without pulmonary manifestation. Do you want to give them prophylactic antibiotic?
Of course not.
Somebody is telling to you dexamethasone and tocilizumab is an indication to give a prophylactic antibiotic?
Tocilizumab and dexamethasone means the patient is in the range of moderate to critically ill.
He wants to tell you that this is an indication because they are relatively immunosuppressant.
Well, in this category of patient, we are expecting that the rate of secondary bacterial infection is higher. So I need you to utilize your PCT, your WBC, and the trend, the clinical trend.
So that antibiotic here will be a prophylactic antibiotic, or it is just in case as well?
Well, both of them, prophylactic or just in case, is not acceptable. We know this from the practice.
So in those circumstances, you will still make the same monitoring to signs of infection, including this before you start the antibiotic.
This is the ideal situation. If you put a case in front of me now, I may behave differently, but this is the ideal situation where we should not give prophylactic.
No. I just wanted to make sure that the audience are getting your message right.
Yes.
Because the same question, and we still have the same 80% answer yes. without putting any consideration to what do we mean by bacterial co-infection, what do we mean by the signs of bacterial infection which require an antibiotic use.
Exactly. And Dr. Ashraf, if we make a conclusion, one message from this presentation, cases who are admitted to the ward, at least better to avoid give them antibiotics. At least leave the ICU patients and the critical patients. We are doing a very close monitoring for these patients. We know who's at risk of MRSA, who is at risk of secondary bacterial infection, or who is immunocompromised. But at least the vast majority, they are taking it in the ward or at home. Many people are taking azithromycin at home because they hear from their neighbor or doctor or that azithromycin should be taken, although there is no evidence for this. This is one simple example.
That is the social media driven medical management of disease. Yes. Thank you very much, Dr. Dirar. Thank you very much.
Hello, my name is Katja Wartenberg. I'm co-chairing this session with Yasser Abu Hassan, who he and I would like to say good evening. Welcome to our neurocritical care session this year, all in the name of COVID-19. And with this, I would like to hand over the microphone to Yasser.
Yes. Hi, good evening and welcome. My name is Yasser Abu Hassan from Kuwait University, and I'm honored to moderate this session, Neuro COVID-19 and Beyond. I will be, as Katja mentioned, we will both be moderating this session. Katja is actually zooming in now with us from Germany, her affiliations here with the University of Leipzig. So what we're going to do is during this session, please feel free to submit questions through the Q&A parameter, through the Q&A Jordan at the bottom of your screen at any time. We at the end of this 5 talks, we're going to be addressing a panel of our 5 esteemed speakers and ask them the questions that you submit. To start, I would like to introduce the first talk, which is by Dr. Jose Suarez from Johns Hopkins, Baltimore, USA, who is going to be presenting cerebrovascular complications of COVID-19. I'm guessing we will be moving to, yes, the talk by Dr. Jose Suarez now.
Well, thank you very much for the invitation to present at the Hybrid Emirates Empirical Care Conference Series. I'll be more than happy to talk to you to share some of our knowledge about cerebrovascular complications of COVID-19. I do not have any conflicts of interest to disclose. And I think we'll start with a description of neurological manifestations and present the current literature. And I would like to share with you what we have built, the global consortium GSS Neuro-COVID, and see where the future of COVID and neurological disorders is. I think we're all familiar with the structure of the SARS-CoV-2 virus. I don't think we need to talk about this, but just to show you a little bit about the epidemiology. I think we all know that about 80% of the patients that are infected can be taken care of at home. The majority of them will have some viral persistence, and 20% of them will need to come to the hospital, and 6% will have to be in the ICU. And those are the patients that usually present with a significant number of neurological problems. So what do we know thus far about the neurological manifestations? I think the implications of acute neurological dysfunction can possibly be explained by 4 different pathologies or underlying mechanisms. One of them will be probably direct viral invasion. That would be one theory, meaning that the virus can access the brain either via the cribriform plate and olfactory bulb, or via hematogenous spread, or just invasion of the medullary cardiorespiratory center. The latter was a possibility because we were noticing that patients, when they came into the ICU, they were in a hyperarousable state and they were requiring a significant amount of sedatives. There's also the possibility of infectious complications or simply just neurological manifestations of systemic disease, meaning that the patient may have hypoxic brain injury or immune-mediated injury due to the cytokine storms, right? And obviously, we needed to explore all those possibilities. And I think you're also familiar with what happened back in the spring of this year, when a lot of reports were appearing in many journals, including the New England Journal of Medicine and the Lancet, claiming that patients with COVID had significant problems with neurological disorders. And obviously, in my mind, this was all sensationalism, and it was probably just everybody was looking for the 15 minutes of fame. And as you can see, there were multiple meta-analyses. By the summer, there were at least 50 meta-analyses that had been put together, and several retrospective studies. And you can see the incidence of neurological problems ranged from 6% all the way up to 36.4%. And it was clearly that it was probably more common in patients that were in the ICU and possibly associated with increased mortality. And I think this is what we can say, that about 36% up until that point, but you can see there were only 214 patients that were published at that time, and 6% of them had neurological ischemic strokes or cerebral sinus thrombosis or hemorrhages, and a significant proportion of them had encephalopathy. And so the limitations of those data, obviously, they were largely retrospective, and none of them have reported the underlying COVID-19 prevalence rate of the hospitalized patients at the time of these cases. And there were multiple sources of biases. So obviously, there was selection bias, misclassification bias, and lack of prior neurological history that was not reported at the time, right? So then there was this study that was published from an ICU in France, where they reported the outcome of their patients that were in the ICU with neurological disorders. And as you can see, these were patients that were pretty sick. They also divided them into two groups. They got the patients who had delirium, delirium and abnormal neurological examination, and those with delirium, no delirium, and normal neurological examination. As you can see, there's differences. The patients with delirium were sicker, obviously, and they tended to stay in the hospital longer, and they required more ICU care. And this is what they also reported. As you can see here, the mortality is much higher in those who had delirium. The length of stay was significantly higher as well, and they required a significantly higher proportion of sedatives, just like we have found here also in the United States, and other colleagues around the world have also reported the same. Of interest, they did spinal fluid analysis in 25 patients, and out of the 25, they found that one of them had a positive PCR for the SARS-CoV-2 virus. This was unusual because we also had done our CSF studies here at Hopkins on a larger proportion of patients, and all the CSF that we found were completely normal. We were not able to find any neurological, any abnormalities in the CSF. Now, of interest, they reported the MRIs of patients that, several patients that were in their ICUs, and as you can see, the patients have microhemorrhages in multiple regions, both hemispheres and the cerebellum. This is very similar to what we find in patients with sepsis. So I think probably what's been happening is that these patients are very critically ill. They could be hypotensive or hypertensive. Then maybe the cerebral autoregulation is altered, and that's what we end up with. So this is similar to what we find in severely septic shock patients. So there's not much of a difference there. Now, we have put together the Global Consortium Study on Neurological Dysfunction in COVID-19 that we call the GCS NeuroCovid, with collaborations from the Neurocritical Care Society. And as you can see, two of our esteemed colleagues, Sherry Cho at the University of Pittsburgh and Erica Fink, also University of Pittsburgh. Sherry is an adult neurointensivist, and Erica is a pediatric neurointensivist. So they decided to spearhead this program with the support and the sponsorship of the Neurocritical Care Society. And as you can see here, we sort of moved fairly quickly. We started putting the group together back in March, knowing that the first case that was reported was probably in November of last year, but we made significant progress fairly quickly after that. So the consortium has over 218 adult sites, and we have all the case report forms for research in English, Spanish, and Portuguese. And we also collaborated with other global partners, including the European Academy of Neurology, that has more than 230 sites, both in Europe and Africa, the Latin America Brain Injury Consortium, and the Possible Network also in Latin America. So they have a combined network of about 450 sites. And the idea was to collect data so that we could come up with a better picture as to what's happening. And you can see here, all the dots shows the green dots shows the adult sites, and the the purple dots shows the pediatric, and then the orange are the ones that are working with the European Academy of Neurology. And this is sort of the structure of the consortium. You have the lead investigators. I already mentioned Sherry and Erica, but there's also Molly Magnet at the Ohio State University, Raymond Helbach in Austria, Shrada Mainali also at Ohio State. And from the pediatric arms, we have Courtney Robertson from the Johns Hopkins Hospital and Michelle Shorber from the University of Utah. So obviously we do have the steering committee that I'm a member of that committee. And also you can see these are the endorsements from the different societies. So the idea was to collect data in a tier approach. So we have tier 1, tier 2, and tier 3. The idea is that tier 1 will be the simplest data collection, and tier 3 will be the most complex. So as you can see, we've also working with other organizations to try to harmonize the data collection and try to find common definitions, so we call the CDE, or the common data elements, and we're partnering with different networks across the globe. Interestingly, we did find common ground, and most of the common data elements have been used by everybody else. The other important piece is that we wanted also to partner with the World Health Organization, and we had our inaugural meeting with them in June, and we're collaborating with them to try to spread the word and the news about this process and provide some education also. And these are the, I'm going to present briefly the main points from the pediatrics group. And again, it was a little simpler on the pediatric side, but they also included 2 aims. And one, of course, was to determine the prevalence. That was the first, the neurological manifestations. But they also wanted with aim 2 to measure child and family health functions, which is obviously critical for the pediatric population. As you can see here, all the pediatric sites are participating around the world. And of course, with the same thing as with the adults and with the children, we're trying to provide support to the sites that are participating and trying to follow those patients long term. That's really the key. This is our first publication. We did publish this paper in Neurology that just came out. It was a prospective study of neurological disorders in hospitalized patients. And we included only in New York City. The reason for that is that they had the disease, at least in the United States, the longest, and they had a significant number of patients with very good data collection that we could get information from. And the first point that I wanted to tell you is that obviously this included a larger number. The sample is much, much larger, almost 5,000 patients. And once you have all that, the population, the entire population with COVID that was seen across that hospital system at the Mount Sinai healthcare system, then we realized that the frequency of neurological disorders is much lower than what was reported in the literature. I was showing you values up to 36%, but really when you look at it, it's about 13.5%. So this is a first teaching point. It's probably lower than what people have reported before, simply because they did not include the entire denominators of the entire population that was seen. The other point is that the most common neurological manifestation is a toxic or metabolic encephalopathy. And I think this is probably driven by the cytokine storms or the genomic storms that these patients have, but also by those findings in that MRI that I showed you probably are also driving this encephalopathy, similar to what happens in patients with sepsis. Yes, patients do get strokes or TIAs or hemorrhages, but as you can see, it's not, the frequency is not as high. We also found some patients that came in and were diagnosed with Guillain-Barré or myopathy or neuropathy or movement disorders. The problem with this is that it's hard to tease out whether they develop the symptoms later and then were found to have COVID or had COVID before and that precipitated the disease. So that's a little bit more complicated. Now, when you look at the spinal fluid analysis, similar to what we found here at the Johns Hopkins Hospital and the state of Maryland, for the most part, the spinal fluid analysis, the CSF, the cerebrospinal fluids were normal, including the PCR that were negative, in this case, 100%. So this is similar to our experience. And then, you can also look and find some differences in those patients that had neurological disorders prior to admission compared to those who developed after admission. As you can see, there was a significant number of patients that had some neurological history prior to coming to the hospital. And those patients who had prior neurological history actually had a lower mortality rate compared to those who developed neurological disorders after admission. So the mortality was higher in that group. So to conclude, I think neurological disorders can be seen in patients admitted with COVID-19. Patients with neurological complications have an associated higher ICU and hospital length of stay and in hospital mortality. But I think we need further research that is needed in this area. And I think what we're doing with the COVID consortium, GCS NeuroCovid, it makes perfect sense. And we're trying to collect data not only from adults, but also from children. And I think having data from all over the world will definitely help us put the pieces of the puzzle together and generalize whatever information we obtained. So stay tuned. I think we'll continue collecting data. There will be another publication coming out soon with a larger sample, not only just including data from New York, but including data from different regions of the world. Thank you very much. Thank you for your attention.
Thank you very much, Jose, for your wonderful summary of the neurological complications after COVID-19. Our next speaker will be Majid Mutari from Shahid Beheshti University in Tehran. And I very much appreciate that he's made the time to record a lecture because he's been extremely busy taking care of the COVID-19 patients. He will speak to us on non-vascular neurological complications of COVID-19. Thank you.
Hello, everybody. This is Majid Mokhtari, and we have to do this on a webinar. Hopefully next year the situation will be better and we all can see each other and do this wonderful ECCC face-to-face. Before anything, I would like to thank Dr. Hossein Al-Rahma, ECCC team, Katja Wattenberg, Ashraf Al-Houfi, and all other people who have been working very hard to make this happen. I would like to make this comment, this actually quote by Albert Einstein, who says, two things are infinite, the universe and human stupidity. And I'm not sure about the universe. Anyway, the learning objectives will be a brief history of SARS-CoV-2, extrapulmonary manifestations, and neurobiology, neuropathology, cognitive disorders, encephalitis, different aspects of Parkinson, alteration in taste, and neuropathies and myopathies. As you might well know, this is an evolving science, and we are learning every day of different facets of this disease. So I'm just trying next 14, 15 minutes to give you a very short snapshot of whatever literature that I could put my hands on. As you know, late December 2019 wasn't a very good month, and 4 unusual pneumonia cases led in Hubei, Wuhan. It's simply very fast. It took over all around the world with flights going there and where, and the disease was spread like anything. And unfortunately, we had a nearly 1 month delay with WHO announcement, which actually caused quite a lot of harm, apparently. Anyway, extrapulmonary manifestation of COVID-19 disease, you may well know that this disease has many, many different pathophysiological aspects, some of which we are still learning. So it could be direct viral toxicity and entry of the virus via ACE2 and TMPRSS2 into the pneumocytes, and direct cytotoxicity and dysregulation of our AS system. From there, we go into endothelial cell damage and thromboinflammation, and also dysregulated immune response. And as we all know, it is like thrombosis, inflammation, cytokine storm, and you name it, the pathophysiology is quite scary. Extrapulmonary diseases that occur actually involve almost every system. Particular interest is neurological system, and neurobiology of COVID-19 was actually looked at and was proposed from early outset of the disease. Some of them may develop cognitive decline, attention deficit, brain fogginess, Alzheimer-like, Baseline MRI was supposedly important to compare in the future, and neurological involvement of the COVID was a stage in NeuroCovid 1 to NeuroCovid 3, progressing from epithelial cells of the nose, going downstream to damage of the blood-brain barrier, perhaps, and formation of clots and encephalitis and other inflammatory processes in the brain. Whether it is nasal and going to the olfactory cleft and olfactory nerve, or whether we are having a transitory phase of viremia, gaining access into the brain and causing quite a lot of abnormalities with anti-inflammatory and anti-apoptosis dysregulation, going into pro-inflammatory, pro-apoptosis, vasoconstriction, and as you know, injuries of different organs of the body, particularly with the brain, with different aspects of involvement, starting from different types of hemorrhages and cytokine release and inflammation in the brain. Again, the stages were quite nicely elaborated back in May. Well, just a few days ago, maybe, neuropathology of the patients with COVID-19 in Germany, a very nicely done post-mortem paper was actually published. And also, this post-mortem study was including histopathological, IHC staining, and they found, activated astrocytes, activated microglia, and cytotoxic T cells, different areas of the brain, basal ganglia, brainstem, cerebellum, etc., and activation of microglia and infiltration with cytotoxic T cells in the brainstem. Actually, they saw it in many cases. Pronounced neuroinflammatory changes was actually quite an important finding. Very nicely, they depicted in their pathological slides with different types of staining, that there are microglial changes and nodular microglial nodules in different parts, brainstem, medulla oblongata, and also CD4, CD8 inflammation. But very nicely, they actually studied the expression of different receptors in different parts of the brain or different tissues of the brain. For instance, ACE2 in oligodendrocytes and TMPRSS2 and 4 were found mainly in endothelial, in neurons overall, which was quite interesting to see that the affinity of the virus in the brain is quite marked. And then they proposed maybe there is something wrong with blood-brain barrier, and at the level of blood-brain barrier and tissues, they found, of course, ACE2 receptors and inflammation at the endothelial surface, which could have been quite nicely explaining the aspects of pathophysiology of this disease in the brain. Then they went on to find out neurological, neuropsychiatric complications in a UK-wide survey using different databases and different organizations of neuro in UK. And from the very early outset, they believed that these cerebrovascular events, altered mental status, therefore neurology and others also were included in the list. Actually, there were people with altered mental status, maybe like 30% or so of those who had neuro involvement, and also patients with unspecified encephalopathy and people with altered mental status. And also patients with altered mental status could be actually younger. Interestingly, people who developed neurovascular problems were belonging to the older age group, and people with neuropsychiatric problem, perhaps in a younger age group as well. Then we go ahead with the very wide multi-center American study, around 4,500 people who were hospitalized, and 13.5% developed new neurological finding in a median of 2 days only from the onset of their disease. And the most diagnoses there are, of course, toxic metabolic, seizure, stroke, and hypoxic ischemic injury. Interestingly, meningitis and encephalitis were not seen, and SARS-CoV virus 2 was not detected in 18 CSF that they obtained by PCR. And after they very well adjusted for age, sex, SOFA, intubation, mechanical ventilation, underlying diseases risk factor, they saw with very robust p-value that the likelihood of discharge to home was, of course, less in people who develop neurological problems. And also with their nice MRI studies, they actually saw quite a lot of autoimmune-related hemorrhagic encephalitis, ADEM, and also different aspects of hemorrhage. And the vascular part has already been discussed by Dr. Suarez, and the clinical presentation and outcome of SARS-CoV-2 involvement, encephalitis in an Italian, but a smaller study in COVID, but from a large population, they found out that with actually pretty nicely done study with CSF, EEG, MRI, in confirmed cases, and they found out that there are different aspects of the disease, again, demyelinating encephalopathy, ADEM, limbic encephalitis, encephalitis with normal imaging, and encephalitis with abnormal imaging, as depicted very nicely in their sections with acute necrotizing encephalitis, ADEM, etc., etc. So another kick to their study, which was quite nice, was including the modified Rankin scale. And in ADEM and MRI positive, the modified Rankin scale was higher than the other ones, and perhaps disability was higher as well. Well, loss of smell, that we are talking about it for quite a while now, and they found out in their nice MRI follow-up of these patients and PET-CT, PET-MR, they found out that there is not much brain stem or cerebellar involvement, whereas MRI signals perhaps showed some olfactory cleft or inflammation in olfactory bulb and asymmetry, but with quite normal, or at times they saw in their MRI a heterogeneous abnormal signals in their PET MRI findings as well. So delirium, something that we all are quite involved in patients in ICU, and COVID itself is a very suspect that it could be the first sign, particularly in older age group. And in their nice study, they demonstrated that delirium is quite important. Not only does it happen in ICU, but it could be the first manifestation in even before other symptoms to occur. Cognitive deficit, a very nicely done study between UK and US with over 84,000 people who were followed online, and they found out that people are really cognitively deficient, particularly those who are severe. But interestingly, biologically confirmed, non-severe, even non-admitted patients to the hospital showed some cognitive deficit. And they did a very nice breakdown of their findings, global cognitive performance in COVID-19 symptoms with severity, of course, increased, and the dark blue in hospitalized and ventilated patients, and light gray symptoms without patient without respiratory symptoms. And when they broke it down to global cognitive performance based on pre-existing disease, they found out about the liver disease, diabetes, and heart condition, and weakened immune system. They all predispose people to worsen condition. And also when they broke it down into different component analysis of their cognitive function, again, more severe the case, more severe cognitive deficit. And Parkinson's disease, they saw an association between Parkinson's disease in a very large cohort of patients, 78,000 and more, patients who died without Parkinson's disease were actually 5.5, and those who died with Parkinson's disease were 21.3% with good p-value. So there was some association. This study was followed with a pathophysiological proposition that COVID-19 could be a perfect storm for generational Parkinson's disease, whether it is vascular insult, damaging the nerve system, marked systemic inflammation could trigger neuroinflammation, or SARS-CoV virus actually could be neurotropic. and postmortem brain biopsies actually have shown it with the German study recently in the Niagara trial system. And they proposed that again, SARS-CoV virus infection and vascular damage, systemic inflammation, neuroinvasion, and from then on it goes to actually T-cell infiltration, microglial activation, loss of striatal, and it goes on and on with generation of Parkinson's disease as a theory. Persistent fatigue, actually Chinese also from Wuhan city, they showed maybe over 50% of even mild patients, younger patients, demonstrate fatigue months and months after even milder illness. The more severe the disease, the more the higher the markers, the higher the actual magnitude of fatigue. Mononeuritis multiplex, whether it's related to isoacquired weakness or directly related to actually to COVID-19. This is an EMG and NCVS study showing different aspects and different forms of neuritis. Interestingly, persistent shortness of breath, and showing that actually paradoxical vocal cord movement, maybe a neuropathy of the vagal nerve, and shortness of breath due to this. And also rehabilitation, which has to be actually taken very seriously even in ICU. Of course, rehabilitation is much more difficult in BMI over 40, but this is very alarming. Using Manchester Mobility Score at ICU discharge, they showed 9% of patients actually could walk 30 meters after discharge, and mobilizing with or without assistance was only in 17%. Be careful with people who have actually base subskull problem, and also be careful about people who had surgeries and also intracranial hypertension with the nasal swab that we are taking, nasopharyngeal swab, and this is beautiful case reporting a CSF leak and meningitis, and patient actually got better. But what is important is our patient care in ICU. As you know, there is no treatment, no vaccine for now, at least no effective strategies. So ABCDEF bundle becomes quite important. At the end, the disease is very serious. We require actually a well-coordinated, well-orchestrated cooperation amongst nations to tackle this disease, and neurological devastation of long-term effects of this COVID-19 disease has yet to be understood. Thank you very much for your attention. I will be ready for any question.
Thank you, Dr. Majid Mukhtari, for that great talk, especially going over all the details of complications that we see after COVID. However, what I would like to say, please submit any questions you have through the Q&A panel at the bottom of your screen. For our next talk, I would like to introduce Dr. Jamil Dabu from Cleveland Clinic, Abu Dhabi. Dr. Jamil will be presenting on the experience, neurocritical care in the era of COVID-19 pandemic, and he will focus on Abu Dhabi's experience.
Hi, everyone. Thank you to Dr. Rahma and the Emirates Critical Care Conference organizers for the invitation, and to Yasser and Katya for giving me the opportunity to share with you all how we handled the first surge of COVID-19 pandemic in Abu Dhabi, specifically at the Cleveland Clinic and in the Neurological Critical Care Unit at CCAD. Two objectives. As we were going to go through this journey, I will share with you how the first surge affected the UAE overall, Abu Dhabi specifically at the Tertiary Care Center at Cleveland Clinic Abu Dhabi, and specifically overall at the Neuro ICU and Critical Care Institute, how we handled the first surge throughout this journey. And what I'm going to start with, I will start with the key summary slide. And I put this together while I was preparing for this talk and reading all the resources available in statements and guidelines on how to handle this pandemic and the crisis. And really what came to my mind is if you've ever been involved in setting up a unit or a protocol or any program, any healthcare change, you really require all these elements to make it happen. and from staff to bed capacity, supplies and resources, setting up protocols and guidelines, embedding them into the EMR, continuous education and research, and really caring about the staff and constantly communicate all the changes. Really, this is every element is needed for every change, and the pandemic is just another change, but in a crisis emergency manner. So what happened is, right now, this is the current state up until November 17th. This is the data up on November 17th. We have over 50 million cases that are confirmed worldwide and over 1 million deaths, unfortunately. And the UAE, situated here, now has over 150,000 confirmed cases with over 500 deaths. And as you all know, and the UAE, similarly to all other countries, we had a first surge that kind of was late. It happened around April, May, and June, and now we're in the second surge riding that wave with the increasing numbers. But we're going to focus on how we handled the first surge, which carried really the most mortality and hit us hard at the beginning, and not much was known back then. And this is the rate of death that you see that nowadays, as we see across worldwide, the rate of death is lower, although the cases are going higher. But at the beginning, the rate of death, like all other countries, is higher. And this is where we handled the first surge. A word about the Cleveland Clinic in Abu Dhabi. The Cleveland Clinic Abu Dhabi is a hospital that's established, really started with a vision 2006, came to light in 2015 when it opens its first doors. And this is the future where we build our cancer center. It's 364 beds, whereby over the years from 2015 to 19, as you see, we went through the phases of any startup hospital, opening more beds, getting Joint Commission accreditation, certifications, and stroke center certification. And our nursing team got the magnet accreditation. And we have up to 72 ICU beds, and that's the layout of the hospital overall, where you see mainly here, these are the regular floor beds, and these are the 3 ICUs that we have, level 6, 7, and 8, the neuro ICU, medical surgical, and the cardiac ICU. And you'll remember that as we'll talk, and there's level 10 here, as these are the units that half of them turned into COVID-19 ICUs from regular ICUs. A word about our neuro ICU. It's the only dedicated neuro ICU in the country. It's 24 beds. We have 4 board certified neurointensivists amongst other hybrid intensivists and 3 advanced practice providers. Over 60 nurses dedicated to neuro ICUs. Many, if not most, are ENLS certified, and in-unit portable CT and dedicated TCD imaging and non-imaging available in the unit, as well as as I mentioned, we're Joint Commission Stroke Center certified, and we're the designated stroke center in the Emirate of Abu Dhabi by the Department of Health, as we're the only center that can provide the TPA combined by mechanical thrombectomy and neuro ICU care. So how it all started essentially is by this email and calendar invite. As much as we all are not big fans of emails, but I will never forget that early in April, invited by the Chief of Staff to prepare war teams as a directive by the Department of Health for us to turn into a COVID-19 center of excellence, to expect a surge in increase our capacity of ICUs with the same staff. And so to plan for it, as we had some chance to plan for it and learn from our colleagues across the world how to do it. However, planning for an uncertain unknown, although we had the luxury to plan, it was hard, it was challenging, as back then, as you all remember, traveling guidelines were uncertain. There was lockdown and curfews and the ever-changing ways of to confine and restrict, transmission. At that time, even I remember, we weren't unsure if we should put a mask at all times or not. We didn't know what the right formula for PPEs and how to test. The first question was, did you come from Wuhan? Then from the other epicenters. Now, as you all know, we test everybody and anybody, particularly on admission and for emergency admissions. Abu Dhabi went on lockdown, and that's actually my mother right before the airport just essentially shut down. How we turned our ICU, this is the layout of ICU. First, we're going to talk about space and talk about logistics, how we turned the ICU into COVID-19 ICUs. This is the elevator when we come in, enter through here, and then you can exit this is the exit usually, and you have six beds with a nursing station, the Pyxis, and a mirror image on the side. So and then here there are family rooms. So what we end up doing is we turn the family room into donning area, restricted elevators access to all essential workers that are going inside this unit, evacuated and closed all unnecessary offices, nursing offices, directors' offices, locked them out, moved all equipment to outside, and essentially turned on the exit side, the nursing manager's office into a doffing area. So you enter from here after you're done, you see your patients, and you exit. And outside, we set up the conference room, turned to a physician office room. And off we go. That particular day where we see here on the monitor, no patients, that was the transition from a neuro ICU to COVID-19 ICU. We deployed our HEPA filters, emptied all unnecessary equipment, and we made sure our neuro ICU and elevators and the hallways are well labeled, so people, by mistake, if they have access, they know where they're heading into dedicated COVID lifts, and the COVID ICU and the supplies, as you see, were all outside. And as I mentioned, one of really the many essential steps, but this was to me, that was really the epitome of how we prepared this crisis, is the family room turned into a donning area. And donning by itself kind of embeds all the elements that you need to handle the crisis or any change. Why? Because there was a lot of education. There were supplies and resources that need to be taken care of or taken into consideration. There was research and trying to look at how we can reuse our own N95. There were protocols laid out, continuous education and monitoring to make sure we care for each other, and you go in well protected and go out the right way. And you can see here, we identify them by arrows, every station, what do you wear, how do you wear it, continuous education there, and an auditor, actually one of our nurses was there. And beautifully, we also reminded every caregiver that they were heroes right before they go in and take care of these sick patients. Communication was key all throughout this journey. This is our task force, our hospital task force, with daily messages and emails about what's going on to keep us well informed and well involved, be it the international cases number, our CCAD, even the preparedness, our caregivers, how many were infected, how many were tested, how are we doing as far as facility, number of beds and supplies. So we are all in it together and caring for the resources of our hospital. We laid out protocols and EMR, and these are some of them, from managing the COVID-19 with the ever-changing medications to how we resuscitate patients in protected manner, how we did the ECMO, the protected stroke code, how we test for them, and embedding them, as you see in our EPIC EMR, with order sets and even smart phrases. And at the same time, we're doing on and on education. For the many of us that haven't used PAPR for a while, we did many mocks, trained how to use the PAPRs when needed, how we intubate the right way, with all the fine details that accompanies intubating a COVID-19 patients. In terms of the ICU bed expansion, as we talked, we handled the first surge from April to June. We had 3 ICUs, as I mentioned, level 6, 7, and 8. From 72 beds, we turned them into a total of 130 beds. And the 130 beds, they were divided into COVID ICUs and non-COVID ICUs. And the COVID ICUs include our neuro ICU in level 6, the medical surgical ICU, and turning a regular floor bed of 34 beds into low acuity COVID-19. The recovering COVID-19 hypoxic respiratory failure on low dose non-titrable vasopressors. We opened it, supplied it, and had nursing there. And And then the non-COVID ICU, where our cardiac ICU turned into a mixed non-COVID high acuity ICU, and our PACU turned into a 24-bed low acuity non-COVID ICU. So we went from 82 total ICU beds to 130 ICU beds. And really one key element, if you're ever faced to do it again, and we're going to do it again, plan for the return to normality. And that takes as much as planning as doing it the other way. In terms of staffing, how we did it, really following the model and recommendation by the CCM, having one advanced practitioner of the ICU, kind of overseeing a team that may not have much of an experience in the ICU, while we are meeting the patient needs, optimizing safety and preserving the well-being by avoiding burnout and infection. I'll share with you how we did it in a practical model. While we put in an Excel sheet, what do we do on a regular basis? We have 72 beds, 3 ICUs, day shift and night shift. We have 12 intensivists during the day and 5 at night. We know our ICU staff has not changed in terms of number, but we needed to see 100, first of all, 96 beds, and then we expanded to 130 with the same amount of staff. So we added the deployed physicians, be it from anesthesia or GI or HVI, cardiology, vascular surgery, general surgery, or neurology, because the clinics were shut. So they were coming in and deployed to help us. So we said, for example, in a COVID-19 ICU, whereby you have 24 beds of very sick, all intubated, being prone on ECMO. If you can place 3 intensivists there, you will need maybe a help of 1 anesthesiology and 2 deployed intensivists. These 3 will combine to make up for the 4th intensivist that we had, to help support by writing notes, talking to families, while the intensivists can manage the overall, overall management of a critical care like mechanical ventilation and so on and so forth. And when we opened finally the 130 beds with the addition of the level 10, 34 acute lower bed, low acuity regular floor beds for COVID-19, we had to also think about how we staff these 34 ICU low acuity COVID-19 beds. We didn't have staff anymore. Well, we kept it at 11 staff per day. Nothing has changed from the beginning, but we deployed and utilized with coordination with the Chief of Staff and the Office of Physician Staff Affairs. We asked for 4 deployed physicians that will come and help us with 2 supervising intensivists. That was really a practical model that helped us ramp up to staff all the beds and ramp down as more clinics were opening and were recovering from the first surge. Communication was key. We had at some point, as you see here in the previous slide, at some point we had 22 physicians and 27 physicians during the day and 14, if not 17 at night. Every week we sent the weekly assignment, as you see here, on level 6 COVID ICU, level 7 COVID ICU, level 10 COVID ICU. Every individual from the critical care institutes, from the deployed physician, each individual where they should report to on that morning. So we communicate and we make sure the right assignments to the 5 units, to the 130 beds are well staffed and every patient is taken care of. And organizationally, we were well supported as elective surgeries, as you see across the board, were canceled, clinics were closed. So we have more physicians, more nurses, particularly nurses that had ICU experience that were deployed. They usually took another job in radiology or acute floor in clinics that were redeployed, reskilled, and placed in, let's say, low acuity COVID ICUs and low acuity PACU ICU, non-COVID ICU, supervised by senior nurses to help us, help our nursing staff to staff more patients with the same amount of staff. And finally, at the peak of it, while we're recovering, we were fortunate to get from the main campus our colleagues to help us support staff this peak and reopen our services. And off we go. These are pictures from the journey where we made sure we're readily identified. We're caring for each other. We are make sure we have no fever. We're getting regular screens, well protected. We proned on and off numerous patients. We had a proning dedicated team going from bed to prone these patients as they need to. Recruit recovered patients from other hospitals on ECMO. And finally, this is when our support came from main campus and the Cleveland clinics, from nurses, technicians, and physicians and equipment to help us staff this this surge and this 50% almost expansion. How we did it at the level of the neuro ICU, as I said, we went from 24-bed dedicated neuro ICU to COVID ICU, neuro ICU, and non-COVID ICUs. So really what was needed is essentially deploy the right staff. So what we did, we thought about it. COVID-19 ICU was a unit that had multi-organ failure. So we deployed specifically neurointensivists that are fellowship double-boarded with medical ICU, for example, to that unit, versus the neurologist neurointensivist to the level 8. We made sure to duplicate our card, our EVD card, CSF sampling, our equipment, make sure both units are there. And our patients were cohorted, as you see from the logistics side, we cohorted our neuro ICU patients in one pod on either unit to know where our physicians, our dedicated neuro ICU nurses also will go there. And also, as we talked about, we had protected stroke codes, how we approach each individual, how we did the echocardiogram, the timing of it, the MRIs was very specific, because at that time we didn't have the rapid test and we didn't know if they're infected or not, with all the uncertainties that come to minimize the exposure and the burnout for our caregivers. Luckily, we beat it, and I'm proud to say that none of our caregivers got infected. None had burnout. We managed, thankfully, to survive this first surge, even with the same almost standards that we had, same mortality. And luckily for us, we recovered and went back to normalcy even at this stage. And I recommend to all the viewers and listeners to, these are good resources to look at that will really focus on how you handle it by a methodical guidelines way. And I just walked you through an example of a journey at the Cleveland Clinic Abu Dhabi, how to handle it from systems of care to inpatient care to staffing and pharmacy consideration. And this is another thing we didn't highlight, how we had shortages and we had to switch, for example, from fentanyl infusions to morphine and remifentanil to preserve with the supply chain matters and the overuse of fentanyl, as we had to sedate more, for example, or give analgesia more to our COVID-19 patients. As a summary, as I mentioned, this is just a different healthcare exchange, the different, bigger magnitude, more emergency, scary really one. And all the elements have to be in place, from frontline heroes to having the right bed capacity, the right appropriate retrofitting all your negative pressure rooms, the ICUs into negative pressure rooms, the PPEs and monitoring the supplies and the pharmaceuticals, have protocols and guidelines continuously set and updated, integrated into the EMR, ongoing education, ongoing research to contribute to the world's rapidly emerging research to help fight this pandemic, and constant communication. We all care about each other, always keep caring about each other. You are all heroes, and thank you for giving me the opportunity to share with you our journey.
Thank you very much, Jamil. That sounded like a very organized battle that you won for now. I hope you're going to be also successful during the fall and winter months. We're going to continue with Mary K. Bader from Mission Hospital in Mission Viejo, California. And she's going to talk to us about crisis management during the COVID-19 pandemic.
Hello, I'm Mary K. Bader. This lecture is Crisis Management During the COVID-19 Pandemic. I'm a clinical nurse specialist from Mission Hospital, Mission Viejo, California, and the immediate past president of Neurocritical Care Society. And I do want to thank the organizers and Dr. Hussein Al-Rama for the invitation to present today. Objectives are listed on the slide. We are going to look at key strategies for managing a pandemic within a hospital and critical care services. We're going to apply an evidence-based framework in managing critical care service during the COVID-19 crisis. And we're also going to explore a model of care for critical care that enables the team to approach how we manage the crisis day to day. We're also going to evaluate nursing staff models and managing crisis staffing for ICU step down and medical surgical units. The neurocoronavirus 2 infection began or originated in Wuhan, China in December of 2019. From this timeline from the World Health Organization, you can see how the virus left China, went to Japan, went to other countries, and then basically became a pandemic around the world. The latest 2 statistics that were gathered when I put this lecture together in October is that there were over 39 million cases worldwide with over 1 million deaths. And from the map, you can see the distribution of the cases. When we examine the response of how not just our hospital responded, but how did the world respond? We turned to the World Health Organization, which gave out specific guidelines in its strategic preparedness and response plan. It established steps that were needed to look at international coordination to support how we deal with the process. We needed a clear and transparent global process for research and innovation, for fast tracking and scaling up and developing therapeutics, vaccines, and diagnostics. And we all had to scale up preparedness and response operations at the national level. They also recommended that governments and society take ownership in preventing the spread of the disease. And so as we look at how the virus spread throughout the world, I'm going to take you down to a local level. So first case reported in the United States was actually one of our sister ministries, the Providence St. Joseph Health System. And the first case in the United States was in Washington at Everett Hospital, January 19, 2020. And the first case that we experienced at Mission Hospital was March 12th in 2020. And so I will ask the audience, when you heard about the pandemic, when you heard about the coronavirus, how familiar were you with the ICU disaster plan? How involved was your ICU team in planning, responding, and managing the pandemic? And when the cases began to enter your facility, did you consult or access literature on society websites or conduct a literature review? And there's a lot of information that's out there on how we respond to a pandemic and how we should manage a pandemic within our own organization. And so when most institutions, I would say most all institutions, do have some sort of pandemic crisis disaster plan within their organization, most organizations, when you look at a hospital or a health system level, usually establishes a hospital incident command center, which sets up leaders to manage the different aspects of the crisis. So when there is a disaster or a pandemic, you have to have in place a plan for how the hospital is going to mobilize itself. When we go into the hospital environment and look at how hospitals should respond to the pandemic, there are many society recommendations out there. This happens to be the European Center for Disease Prevention and Control, which gave recommendations on infection prevention and control of patients with the coronavirus. And they recommend identification of patients, initial contact and risk assessment. There has to be a community plan for how the area manages the pandemic. How do patients access the hospitals within that community? And in the hospital itself, the hospital must have an administrative plan. How are you going to respond? What units are going to be involved? You're going to have to look at capacity, patient management, how the patients are triaged and transferred within the system, and then what type of PPE is going to be immediately available. They also recommend exploring how the institution does environmental cleaning, waste management, and lab management. I'd like to take you down to an ICU-focused response, looking at how does critical care services respond to a pandemic or a disaster. One of the great resources that's out there is from Farmer, Wax, and Baldessari, published in 2012 on ICU disaster response. And that's what you see in the box on the right-hand side of your screen. There are many steps that need to be taken before the event actually happens. Exploring what is your ICU capacity, doing a hazard vulnerability analysis. Who are the stakeholders in your ICU? The leadership, both physician as well as staff leadership. And then it says, how does your ICU operationalize during a disaster and pandemic? Building a multidisciplinary team, knowing who those leaders are who are going to lead and manage the crisis. Ensure the ICU plan has proper staff safety and well-being, and that the ICU-based command and control center has a strategic plan on how we're going to be managing the pandemic. There are different kinds of disasters. There are brief disasters, which may entail a few days. And then there's this pandemic crisis, which is taking months to now almost a year in its duration. And so it's going to tax the system in different ways. I would like to suggest that it's imperative that your critical care service have a model to manage and navigate that ICU response during surges, as well as during the initial stages of the pandemic. One of the best resources is John Hick et al., the Surge Capacity Principles that were published in CHEST. It's a CHEST consensus statement from 2014 that explored care of critically ill and injured patients during pandemics and disasters. And this provides you with a framework on how we're going to manage the pandemic. Now, there are 3 different frameworks that you need to look at when you're dealing with a pandemic or a disaster. And that is the concept of conventional, contingency, and crisis. And these words need to be used in your weekly or daily briefings with your critical care team. A conventional mode is when we, as an institution or a critical care service, can expand about 20% above maximal ICU capacity. Contingency is when we're expanding our critical care services by 100%. And crisis is when we're expanding it by 200%. And the staff model that is recommended in the CHEST consensus statement is one in which we use a model of space, staff, supplies or stuff, and standard of care system strategies. And within this model, it gives recommendations on how to move from conventional contingency to crisis. So what I would like to do is share with you, this is our response at Mission Hospital in Mission Viejo, California. And when the pandemic hit, I had just returned from a neurocritical care board of directors meeting. And the next day, our first COVID patient came into the institution. So I quickly, as the clinical nurse specialist, talked to our director of critical care, posed a PICO question: how do we, a non-academic hospital ICU, apply pandemic and COVID-19 management guidelines to optimize our readiness, maximize resource, treat patients during the peak surge of COVID-19? I conducted a literature search, looked at all the relevant sources of literature. There were 30 sources of evidence that were compiled, and I went through this with our director of critical care, our physician director. And so we came up with a plan. We created a COVID-19 task force, and this was a multidisciplinary group of ICU, ER, trauma, infection prevention, administration, pharmacy, nutritional care, ethics, our children's hospital, respiratory, quality, and palliative care. And we met as a team 3 times a week for an hour. And we used that standard CHEST model to apply what was going on. We had agenda and minutes that I would create. I would take the minutes. And we also deployed a constant review of literature on COVID-19 to make sure we were staying current. And so to show you this model, the model we adapted, which is the CHEST model, we had space, staff, supplies, and system strategies. Excuse me. So under space, we elected in our institution, we had 51 critical care beds. We designated 1 critical care unit as the COVID ICU to begin with. But in the contingency plan, we then designated a second critical care 27-bed unit to come up next as the COVID ICU. And then the 3rd critical care unit would be under crisis. We took a look at how we would convert non-ICU areas into intensive care units in the contingency phase. So as a team, we came to consensus. The neuroscience post-anesthesia unit would come up as the 4th ICU. The inpatient main operating room PACU would come up as the next critical care unit. And in crisis, we began exploring those other areas that we could designate. So in this slide, we show, or I show you, our space plan for contingency and crisis. When we explored our staffing, so how do we manage staffing as we escalate the number of patients that are in the institution? So when you are in contingency, which means you're filling your normal ICU beds, you have normal ICU staffing. Now in contingency, we're opening more ICUs, we're requiring more critical care units. So how do we extend, how do we add critical care nurses when you have a finite supply? So you have to look at your physician availability, you had to look at the nurse availability and the respiratory therapist if you use respiratory therapists in your ICU. So we immediately turned to other areas like our post-anesthesia care units, interventional radiology, emergency department, anywhere where there had been a nurse with prior ICU experience. We brought that ICU nurse back into critical care, did some staff orientation over 1 to 2 shifts, and immediately began deploying nurses back into critical care. When you get into a crisis model, you're now looking at how am I going to manage these more ICU patients than I have nurses. And so what we developed was an actual contingency and crisis plan. And that's what showed on this next slide. So we had an ICU contingency crisis staffing model. We had a telemetry model staffing and med surge. And you can see that in 1 to 3 contingency staffing, we had 1 ICU nurse to 3 critically ill patients and 1 non-ICU nurse. We could adjust that into crisis with every 6 ICU patients to have 1 ICU nurse, 3 med-surg nurses to these 6 critical care nurses. So we actually devised the staffing plan for the entire hospital. Supplies, the constant need to know how many ventilators, do you have enough PPE? Do you have enough drugs, pharmacology supplies? Do you have enough IV pumps and monitors? And so in our contingency and crisis plan, we spelled out the adding of 37 more ventilators, making sure we had enough high flow devices like Airvo devices, making sure we had enough medications, and when we didn't, creating or adding different medications into that. Then the system strategies, we had to expand disease-specific protocols for COVID-19. We altered our PPE guidelines according to the CDC. We built PPE boxes and different cardiac arrest algorithms. We developed additional neuromedical pharmacologic protocols that would serve our team as we managed this crisis. So this is, for example, how we managed cardiac arrest, which is an aerosol generating procedure when that occurs in critical care in the emergency department in med-surg. Here's an example of several different clinical guidelines we also developed during this pandemic. So in summary, navigating the COVID-19 crisis requires that there is preparation in advance, that you know as a team how to organize given the type of disaster, that there is a constant review of the literature. Using an ICU surge capacity model of space, staff, stuff, and system is very helpful. Inviting key stakeholders, meeting regularly to assess and reassess your response, and then constantly adapting, communicating, and evaluating. This is this list of references. We actually did publish our article and our response in Critical Care Nurse. That publication is number 27. Thank you very much for the opportunity to share how to manage a critical care pandemic crisis. Thank you.
Thank you, Mary Kay, for sharing your experience. And I totally agree with you. This pandemic has taxed everyone, taxed them very deeply, actually. And we are living the burdens of this. So for our 5th and last but not least talk for the day, I would like to introduce Dr. Sherry Cho from University of Pittsburgh, Pennsylvania, US. And she will be presenting research in neurocritical care during COVID-19 pandemic. So let's start with Dr. Cho.
Good evening. I want to thank the organizers of the Emirates Critical Care Conference for this opportunity to speak, and I will speak to you today about research in neurocritical care during the COVID-19 pandemic. My name is Sherry Cho. I am a critical care physician, a stroke neurologist, and a research scientist at the University of Pittsburgh. I do not have relevant disclosures other than research grants from the government and from my institution. As of 3 days ago, the world has surpassed 60 million cases of COVID-19, with the epicenter being here in the United States with over 12 million and mounting deaths. In a pandemic this far-reaching, neurological symptoms, even if they're rare, is a major public health crisis, particularly because when the nervous system is involved in a systemic disease, we know patients often have much more severe morbidity, higher mortality, and a much longer road to recovery if there is any recovery. At the very beginning of the pandemic, as reports of neurological involvement of SARS-CoV-2 began to emerge from different corners of the world, we thought through carefully what are some of the possible ways the SARS-CoV-2 virus may impact the nervous system, and we drew from our experiences with other infectious pandemics. Here are 5 major categories that we considered. The first and the most concerning category is a direct viral invasion into the central or peripheral nervous system. An example of that would be the West Nile virus or the herpes simplex virus, where the viruses will enter the nervous system and directly attack the neurological tissue. Another major category that we must consider are the para-infectious or immune-mediated processes. Things like the acute disseminated encephalomyelitis or ADEM, transverse myelitis, or Guillain-Barré syndrome can cause significant amount of morbidity and mortality to the hosts that experience these conditions. Next, certainly we need to consider neurological complications of a severe systemic disease. So for example, we've heard about the involvement of the coagulation system in COVID and hypercoagulability leading to ischemic strokes. We heard about the severe hypoxia that can happen in COVID-19, and we must consider hypoxic brain injury as a result of the severe respiratory failure. And then, of course, in severe sepsis, we know that a large proportion of patients can develop encephalopathy and delirium. We also must think about the patients who already have a neurological condition. What may happen to them if they became infected with SARS-CoV-2? For example, our epileptic patients may have increased seizure frequency or be pushed into status epilepticus. Our patients with neuroimmune disorders may get worse after an infection or vaccination against the SARS-CoV-2 virus. Finally, we must consider that our therapies or empiric treatments that we try to offer patients with COVID-19 may also impact the nervous system. For example, anticoagulation could lead to important hemorrhagic complications, particularly in the central nervous system. The patients who have respiratory failure, who receive steroids and paralytic medications, are prone to having critical care illness, neuropathy, and myopathy. And the long-term sedative use for patients who are on mechanical ventilation can lead to delirium and encephalopathy. Even though we thought through all of these possibilities, and as the case reports continue to emerge from across the world, there are some very important and critical knowledge gaps that still remain. What are the main types of neurological manifestations of COVID-19? And what is the prevalence of these main neurological manifestations? In other words, how big a problem is this? How many people have this problem? And when these neurological symptoms happen, are they directly caused by the virus attacking the nervous system, or are they a coincidence or a side effect? Finally, what are the outcomes of these patients who develop a neurological manifestation of COVID-19? How do we know who is likely to develop neurological symptoms and why? In order to answer these key questions, we realize that we must quickly and rigorously design a way to do research in the middle of a pandemic so we can find some key answers to these important questions that we really need in order to take better care of our patients. And yet, we have a global pandemic, so we must think out of the box. There are many, many more barriers and difficulties to doing research in a global pandemic when healthcare systems are being overwhelmed, when everybody needs to consider the risk of infecting anybody who is working in research on these patients. And these are the new realities that we must face, and we must adapt ourselves quickly. It was under these circumstances that the GCS NeuroCovid Consortium was born. This is a timeline of the early phases of the development of our consortium, from the time that the virus was reported and COVID-19 was discovered, to the final declaration by the WHO of a global health emergency in the end of January, and the US declaring national emergency on March 13th of 2020. We quickly designed a very, very pragmatic study to attack this problem and formed the GCS NeuroCovid Consortium at the end of March of 2020. In this figure, you can see the black line represents the number of sites registered to participate in the consortium, and the gray line represents the number of countries that the consortium reaches. And within a mere month after we've developed the consortium, we were very, very grateful to find that there were over 100 sites worldwide that have registered to participate in this consortium. Within a month of developing the adult study, we also formed a pediatrics arm and designed and developed a parallel pediatric study to capture the neurological manifestations in this important patient population. And you can see that once registration opened, our numbers jumped up very quickly. I will give a current update of the consortium later in my talk, but we're almost at the double of this initial number currently. But there are some very important considerations that we need to think through in a pandemic, things that we never had to face before when we designed studies in neurocritical care. Something as simple as inclusion criteria. How do we know which group of patients to capture? Here's the problem. There was very limited testing, at least within the United States. In the early part of the pandemic, testing was very limited. And with limited testing, how do we define who is the COVID-19 population? We decided to take a pragmatic approach. We decided we would include all of the patients who had a confirmed PCR study that confirmed SARS-CoV-2 infection, but also we will include what we call person under investigation. These are patients whose clinical presentation are highly suspicious of COVID-19, but who either tested negative or more commonly could not get a test. And these patients are also included under this pragmatic approach. Furthermore, we decided for the first phase of our study, we would restrict enrollment to only hospitalized patients. The reason for this is hospitalized patients tend to have more severe COVID-19, and these are the patients who are much more likely to have more uniform testing, and we would be able to capture a more uniform population as compared to the patients who are not admitted to the hospital. Many of them dwelling in the community may have COVID-19, but we simply do not know because we don't have enough testing. The second big important question is, how do we define the disease? In a pandemic with, especially at the beginning, when medical systems are overwhelmed and we're learning how to operate within our health system under this new infectious disease concerns, many of our usual routine diagnostics were not available to us. And so how do we define a stroke or encephalitis or all these other neurological syndromes? We decided again to take a very pragmatic approach, and we decided that as a first take, in our first step, we will describe the clinical syndromes. In other words, we want the symptom phenotypes. This data should be readily available by taking a history and by the bedside examination of a patient without requiring any additional diagnostics or testing. And we also want to make no assumptions of the pathological diagnosis. So for example, we will collect data such as paralysis, but we will not make an assumption as to whether the paralysis is secondary to a stroke or to some other nervous system injury. Secondly, we know that we must not assume that a neurological specialist would be available to help collect these clinical syndromic data in a pandemic. It was our responsibility as researchers to create data elements and definitions that are simple and practical so that any trained clinicians on the front line taking care of these patients can accurately and easily capture this data without needing additional specialized neurological training. This triangle here captures our view of how we would design this study. We realize that we need to bring this information to the world fast, but we need to perform the right study rigorously so that the information is accurate. And therefore, we came up with this tiered approach. Tier 1 is what we call the study at the time of war. It's the study that we aim to launch even as the pandemic is attacking the world, overwhelming healthcare systems. This is a very, very pragmatic tier of study where we want to capture the most important information that we want to capture. And we want to capture prevalence. So this is not a registry study. This is a cohort study where we actually capture a group of patients over time so we can determine out of all the patients with COVID, how many patients have these neurological symptoms. As we conduct tier 1, we then will build, design, and get ready to launch tier 2. And the idea here is we will learn from the tier 1 study what are the major neurological symptoms that we need to focus on. And then tier 2 would allow us the opportunity to go in and focus on them, collect additional clinical data that we wish we had collected but couldn't because of the limitations of the pandemic. Most importantly, in tier 2, we would also begin to look at long-term outcomes of these patients beyond their hospitalization, so we can begin to understand the impact of these neurological conditions associated with COVID-19. Finally, as we design and conduct tier 2, we will design and get ready to conduct tier 3 study. And tier 3 is what we call the translational and experimental arm. This is where we go further in depth into these main neurological syndromes, and this is where we do want to use advanced imaging and biomarker technology to understand the disease pathophysiology and mechanism so that we can have a window into how we may treat and design a treatment for these conditions. The triangle here represents the number of sites and people who can participate. The idea is tier 1 is minimum burden, that any center interested and wishes to can register and participate without needing much resources on their side. Tier 2 would be more advanced, would have more data elements to collect, so the burden of data collection would be a little bit higher. We still expect that most medical centers that take care of COVID patients should be able to participate in this tier should they be interested and wish to. Finally, tier 3, because it requires advanced imaging and biomarker technology, probably there will be fewer centers who will be available and willing to participate in this tier, and hence the triangular design here. This slide is simply to say that the rationale and the detailed design considerations of this tiered approach has been published in the Neurocritical Care Journal, and I will share the reference for this paper at the end of my talk. This article is free for download from the Neurocritical Care Journal. A very quick mention on our consortium structure. So the GCS Neuro Consortium has 2 arms. There are 4 of us in the adult arm, 4 investigators from the United States and Europe, and we have 3 investigators leading the pediatrics arm. Both the adult and the pediatrics arm are being coordinated out of the Central Coordinating Center, which is the University of Pittsburgh. We're very grateful to be endorsed and supported by the Neurocritical Care Society, the Neurocritical Care Research Central, and the Neurocritical Care Research Network. Similarly, we're very grateful to have a group of world-renowned experts serving as our steering committee to give us advice and help guide us as we further develop this consortium efforts. As the latest update, the GCS NeuroCovid Consortium currently has over 227 sites registered from across the world. Of these, 124 are adult population sites and 103 are pediatric sites. As we speak, we at the Central Coordinating Center at the University of Pittsburgh is working with all these sites to establish local ethics and IRB approval, as well as data use agreements so that the data can be sent to the central site for final collection and analysis. As part of this international effort, we have also translated our case report forms into Spanish and Portuguese for both the adult and the pediatric studies. We're very, very grateful and happy to have the formal collaboration and support from the European Academy of Neurology. The EAN has an energy network studying neuro-COVID phenomenon, and the network currently has over 220 sites covering mostly Europe and Africa, but extends worldwide. And the global coverage of the EAN network is almost perfectly complementary to that of the GCS NeuroCovid, which I will show you in the next slide. We're similarly grateful to have friends and formal collaboration and support from the Latin American Brain Injury Consortium and the Possible Research Network situated in Latin America. Putting the whole network together along with our global partners, the entire network currently sits at greater than 450 register sites worldwide. This map is a summary of where the network was back in July of 2020. It is more extensive now, but I want to show this figure to illustrate where the geographic regions that we would cover. The green dots here are the registered sites for adult population study for the GCS NeuroCovid Consortium. The red dots are our pediatric sites. The yellow dots are the European Academy of Neurology Energy Network. And as you can see, while centered in the Americas and Europe, the consortium indeed extends worldwide. Another very important point here is the use of common data elements. This is one of the major scientific efforts that we make in order to contribute and to be able to eventually harmonize and combine our data with other major global coalitions. I mentioned the EAN Energy Network earlier. In addition, we're also working with the Canadian Trials Network and the general COVID research networks to harmonize our data elements as much as possible. Here I share some of our publications and the link to more information with our global forum. And with that, I want to thank you for your attention.
Thank you very much, Sherry, for this wonderful summary of a great initiative. And this initiative is also a very good example for international collaboration. Now we have our question and answer sessions. We have a few questions here. I would like to start with the first one. I guess that's one for all of our speakers. There's a question if anybody experienced a brain hemorrhage in a patient who actually recovered from COVID-19 and was stable a few months or a few weeks after recovery.
Was the question about what to do after a hemorrhage if the patient has recovered? I didn't get it.
The patient had recovered from COVID-19 and then experienced a brain hemorrhage. If one of you also encountered this problem, or I guess the question is if the brain hemorrhage is somehow related to COVID-19 or not.
Yeah, I think that's an interesting question. I think it will be hard to assume that is related to COVID-19. I mean, the hemorrhages that we've seen have occurred in the hospital, but these are patients that usually have been on full anticoagulation because of other complications like pulmonary embolism or DVT in patients with COVID-19. But we haven't seen a case of someone who has left the hospital, has come back with ICH. I have not seen it yet.
Okay. And I have a question for Majid. The question is there a treatment for long-term fatigue syndrome?
Well, myself, I also haven't seen, going to the first question, I haven't seen any cases recovering fully and coming back with a CVA, which could be very well unrelated, as Dr. Suarez also put it in his own words. As far as fatigue is concerned, over 52% of people in Wuhan city who recovered, and after maybe months and months after their recovery, they're still not back to work. And there are a lot of people who complain of fatigue, whether this fatigue is related to some kind of neuropathy, myopathy, or some central nervous system events. We are still at its infancy. At least I'm not aware of any kind of treatment, if you like, apart from general good care of the patient, very, diligent attention to the initial care of the patient, and preventing hypoxia and preventing all those complicating factors and other general good care, which might prevent further fatigue. But then again, as I said, I do not have, and I do not know of any treatment for it. If anybody else knows, please let me know.
Thank you, Majid. Now I have a question to Jose and Majid. After reviewing a few papers on neurological complications in Italy, France, and entire Europe, I was wondering if there's a way to differentiate between the effects of a normal septic shock, which can also lead to microhemorrhages, ECMO can lead to high microhemorrhages, and encephalopathy and delirium, and the actual effects of SARS-CoV-2 in these patients and the association with neurological complications.
Dr. Suarez, you want to go ahead first?
Yeah, I would say probably at this point, I think it's premature. I mean, I don't think we have enough information to tell for sure, what's what. To me, it's looking more like what we're seeing right now. It looks similar to what we see in patients with severe septic shock. And of course, most of the MRIs that we have are for patients who have been critically ill, right? They've been in the ICU. One of the problems that we had was is transporting these patients, right? Getting these patients out of the ICU for an MRI. I think one of the things that may change this equation, but I don't know whether that will be available in enough sites to be able to tell more, is the availability of a portable MRI machine, right? Which is available now. It's available now in the US. A few sites have it. And they are now doing MRIs in these patients as well. And hopefully now with the GCS COVID consortium that Sherry nicely has put together with Molly Magnette and Erica Fink and others, I think that will help us answer this question, whether there is any differentiating factors or MRI findings that can help us determine what's what. I think it's a little bit difficult at this point. The other thing is that there was another paper that came out actually in stroke after we put all this stuff together, where it actually shows that the incidence of stroke in COVID patients is actually lower than the general population. So that was published in Stroke recently, just last week, and so I think we still need more data. This is why, as Sherry was saying, it's important to have the denominator also, because when everybody was publishing back in March and April, it seems to me like it was 15 minutes of fame. Like everybody wanted to get a paper out there, and they knew that at that time it would get published in a high impact journal because everybody wanted to have the news, right? So and now I think that we're learning more I think we can start putting the picture together. Majid, I don't know if you have anything else.
Yeah,
Great
I can
talk.
add.
Great talk, by the way. Great talk.
No, thank you
Enjoyed
very
it.
much. You're very kind to me. Well, Katya, very great question. I really like your intelligence and the way you look at it, and I learn a lot from you. Look, I think let's put it this way: from pathophysiological point of view, this disease is weird. It is causing quite a lot of changes, as we know. I'm not going to repeat it. You guys are masters by now in its whatever we know about its pathophysiology. But as far as the the conditions, the brain conditions are concerned, whether we are going to actually put sepsis encephalopathy or instrument-related encephalopathy or hypoxic encephalopathy into the picture, I think there are much more severe cases. Whereas with lighter cases, with cases who do not even require invasive procedures or invasive organ support, we do see cognitive disorder. We do see encephalitis. We do see a lot of brain changes. One could postulate that this is perhaps the pathophysiology and what happens at blood-brain barrier and what happens with cytokines and the whole lot, which is very unique perhaps to this virus, actually creates this problem rather than the other ones that you mentioned compounds the problem. But the mere fact that we do see all these CNS changes in even much milder people who do not require all those, hoopla, perhaps somewhat has got it has got to do with the pathophysiology. And the second point I want to make about the lower incidence of CVAs, perhaps because now we are anticoagulating people much more vigorously, and our pattern of anticoagulation, even for prophylaxis, has changed tremendously from early outset of the disease till now.
Thank you, Majid. Now I have two questions for Mary Kay and Jamil. One is from the audience. It states they wanted to know about your mortality rate during the first wave. And my question is, with this great model of turning your hospital into a war ICU, did you have any psychosocial support, psychological support for the ones having to take care of those patients who actually also die, and a lot?
Thanks, Katya. It's a great question. I'll start with the mortality rate. So it's close to unpublished data yet, but it's close to 25%. Now, I'll just mention our hospital was part of the tiering by Department of Health. We were tier 3 hospital, meaning we were going to get the severe respiratory failure, ARDS spectrum, even requiring ECMO. So about kind of half of them were in that state, and then more than 2/3 of those were mechanically ventilated. That's as far as the mortality. As far as support, of course, during so I believe when we were facing the first surge and we're focused on staffing all these 5 ICUs and escalating and de-escalating, at the same time our organization formed a well-being team. We have a well-being department that had a focused task to support our caregivers in terms of what they feel and what they need. And then specifically as we were winding down, their efforts ramped up in terms of reaching out individually, even besides the forums and the resources that were made available by email, by live forums, individual. Almost at some point, they reached out to every individual that crossed the double doors of every ICU that was tackled COVID-19. And that's a very important element, not only during the surge, but also after, and individually reach out. I believe that was really important because a lot of people did not even realize what they feel, or they put it together and then maybe they translate it into something in a different way to express, be it their burnout or what they feel about this whole pandemic.
Kathy, if I can make a comment about that, I think one of the points that I think is worth mentioning is that of the redeployment of other healthcare personnel that normally they say don't come to the ICU, they need to come in for instance, a dermatologist, right? A dermatologist or an orthopedic surgeon that they normally do not come to the ICU. So we had to re-educate on the fly and develop educational material for these people to be reacquainted with what was happening in the acute medical wards and also in the ICU. And I have to tell you that, there was a lot of concerns, from the part of the other intensivists. Are you sure you want to bring a dermatologist or you want to bring an orthopedic surgeon? But I always said, and I think fortunately for us, it turned out to be true, that I always said I'd rather work with an enthusiastic dermatology that I know has volunteered to work in the ICU, and I'm sure they'll do everything they can to shine and to prove that they're able to do it, than to bring a reluctant general surgeon into the ICU who may not want to come in, but is obligated to come. And I think that's exactly the way it went. And the same thing happened with the nursing staff too, the nurses that had not been in the ICU before, that were redeployed to help. And I have to tell you, there was a lot of enthusiasm. I'm really concerned is about this second surge that we're seeing now, because people are exhausted, and they're emotionally drained. And I think one of the points that caused the most significant distress, it wasn't the fact that you had to work in the biomode unit, in the COVID units, but it was the fact that you could not talk to families, and you could not bring them into the ICU so they could see their loved ones. And I think that was the point that caused the highest degree of moral distress for all of us here. And we're still dealing with that. And I think we're going to be dealing with that for several years, after this.
Yeah.
And if I may piggyback on Jose's great point, the deployed physicians, besides, of course, giving them webinars of educating them how to do ICU, basics of ICU, which was probably the most well-attended education forum, setting expectations was key. A lot of people were kind of scared, I'm going to go to an ICU, and reminding the cardiologist, the gastroenterologist, the neurologist, you're not going to be dialing the ventilator settings. You're not going to be up titrating, down titrating. All we need you to do is just collect the vitals, speak to the family, support us in these, and reminding them of these expectations was really key to lessen the amount of stress when we were telling them, hey, we're going to need your help in this ICU. And the other one, also we found it really helpful, is when we redeployed physicians. For example, in the non-COVID neuro ICU, where we segregated out, we managed to just deploy their neurologists and neurosurgeons, and they were actually following these patients as a consulting team, and they were knowing these patients. So it was much easier. So if you're able to cohort the patients, the cardiac ICU, you can deploy the cardiologist there. Similarly, in the COVID ICU, if you can deploy a neurologist or neurosurgeon to the subarachnoids with COVID, that will help also tremendously, providing the best care for your patients.
Definitely. Thank you, Jamil. Mary Kay, how did you deal with all these issues?
So when we looked at the staff, the nursing staff specifically, and burnout, we just did although we had resources from our system that were deployed for support, we just recently got the results of a survey from our entire staff, and there is a high rate of burnout. We had a big bump in March and April. We had another surge in July, and now we're in our what we call third surge or third bump up. And I'm more concerned now because I don't think the staff has had enough time to work through a lot of the emotions and issues and the moral distress they had in the July, August, early September surge that we had. And so I am concerned. We are deploying resources, but at the same time, we're so short of staff. We don't have enough nurses. We can't get traveler nurses in. And I live in Southern California, which is a great place to come, but traveler nurses have been picked up by other regions of the country now. So there is a big concern with worsening of the staff burnout. But we, as an institution and as a system, continue to provide them with resources and programs and counseling to help them. We never had a shortage of physicians, and maybe because we're a non-academic community center, we're a 505-bed hospital. We have, I believe, 12 intensivists, and it was enough to manage all the surges that we had. So we had a plan on how to deploy other, anesthesiologists. We don't use anesthesiologists as intensivists in our institution, but we certainly had a resource group of qualified physicians who could take over.
Thank you. There's another question from the audience that does not really affect neurocritical care, but maybe someone of you wants to answer that question. And the question is, why do some patients develop emphysema? Majid, aren't you a general intensivist?
Well, actually, there was this nice review that people who develop mediastinitis or mediastinal layer or even pneumothorax, pneumomediastinum, they might have increased mortality. This, I still don't know why do they get it, whether it is trauma secondary to, mechanical ventilation. Some people, even without mechanical ventilation, I have CT scans to show you young people with no intubation, with no, even with their NIV, very mildly put it, with their high flow nasal cannula, moderate even to severe disease. But I was very glad to read that the patients under 70 years old and people who have no acidosis, pH over 7.26, are less likely to die. So don't worry about pneumomediastinum, don't worry about pneumothorax. This happens in this disease, whether it is related to barotrauma. I cannot, differentiate it now, but the cases that I had, 2 or more cases that I had the CT scans of, and I actually cared for them, they were not intubated. They were prone, they had high flow nasal cannula, but pneumomediastinum and pneumothorax was quite evident. And again, whether it is part or parcel of this disease, I cannot work it out right now.
Well, thank you very much to answer that question off topic. I think we have responded to all questions from the audience, and if there's nothing else left open, I would like to thank all the speakers to donate their time, especially during these very difficult times, working at the hospital nonstop, to record their talks beforehand and to be present here on a Saturday. That's really great of you, and thank you very much, Hussein, for giving us the opportunity to have this neuro lecture within your first or second hybrid ECCC. Have a good evening.
Thank you very much.
Thank you,
Yes.
Fabian. Thank you, Nasser.
Thank you.
I would like to also thank you guys here.
Thank you.
Thank you, Hassan. Thank you, Majid. Thank you, Jamil, Jose, and Mary.
Thank you, Hussein. Thank you very much.
Thank you. It was a pleasure to have you actually on board.
Yeah, see you soon again. See you soon again.
We meet in person, hopefully, very soon.
Yes.
Well, let's hope so.
Of course, we will continue the connection together. It's
Thanks.
a pleasure actually to have you and have other international figures from all over the world sitting together, exchanging our expertise and trying our best to give to our patients, beloved patients. And looking forward for the third day on 12th of December. I enjoyed this collection of all of our friends from all over the world, our network get together, and our audience here on the site. And I hope that everybody online get their needs or whatever they wanted to know, new or international ways of dealing with this pandemic. Thank you, and looking to see you in a few days again, in 2 weeks. Thank you very much, everybody. Thanks.
Thank you.
Thank you, Dr. Hussain. Thank you. Bye-bye.
Thanks. Bye.